evening session. We have the honor of having very eminent faculty today, Professor Chintamani sir, Professor Uday Kumar sir, Professor C.D. Narayanan sir, Professor Kali Ratnam sir, and Uday Kumar is yet to join. And we have our faculty team. We have Professor Khanna sir, Professor Rajiv Sakai sir, Srinivasan sir, Karnakaran sir, and other eminent professors who have been always with us through the journey. Today, we have students from Malabar Medical College and Gandhi Medical College. They are kindly contributed by Professor Ajesh, Professor of Surgery from Malabar Medical College, and Dr. Sridhar and Sadgunachari sir from Gandhi Medical College. So we have two important exam cases, and many states have started their exams. We wish, on behalf of all the faculty here, we wish all the students well for their exams. So we have Professor Kali Ratnam sir, expect to join. Dr. Uday Kumar sir has joined. So welcome all of you, and I'm sure all the faculty here know how the system works here. The student will be allowed to present the entire history part, and then students will be revisited from slide 1, 2, 3. So faculty can respectively give questions and give comments. I request all the faculty to give the answer if the student struggles to answer. That takes the discussion further. And then the student will be presenting the entire clinical part without stopping. Then at the end of clinical part, we allow the faculty to initially discuss about the clinical points. Then they move on to the management part of it. So we have 1 hour for each case, so that we have an extended time for the discussion to cover up perioperative and the investigational modalities and the most recent advances also. So with that plan, we warmly welcome both the students. And the Dr. Aparna from Gandhi Medical College will start her first presentation. Faculty, I request you to please take over. I wish all the participants to keep their mic muted so that the presenters and the faculty alone can keep the mic on for comfort of others. It's a humble request. Thank you very much. Good luck, Dr. Aparna.
Thank you, sir.
Kali Ratnam sir has joined.
Professor Kali Ratnam sir, good evening, sir. He is the head of the department from Kalaslingam Medical College, sir.
Good evening to all.
Yes, sir. Dr. Aparna, you can start your presentation.
Thank you, sir. Good evening, respected faculty. I'm Dr. Aparna from Gandhi Medical College. I'm going to present a case on neck swelling. A 50-year-old lady, laborer by occupation, resident of Balaji Nagar, came with the chief complaints of swelling in front of the neck since 4 years. The patient was apparently asymptomatic 4 years ago. She then noticed a swelling in front and lower side of lower right side of the neck, which was insidious in onset initially 2 into 2 centimeters, gradually progressed to the present size, which is about 6 into 8 centimeters over the past 4 years, which is not associated with pain or fever, and not associated with pressure symptoms, and not associated with symptoms suggestive of hyperthyroidism or hypothyroidism, and it is not associated with any other swellings in the neck, and it is not associated with bony swellings, hemoptysis, and jaundice. Coming to the past history, she had no history of similar complaints in the past. She is a known diabetic since 3 months on regular medication on tablet metformin, and since there is no history of hypertension, cardiovascular diseases, cerebrovascular attacks, and pulmonary tuberculosis, asthma, and epilepsy. And there is no history of radiation exposure in her childhood, and there is no history of excess intake of goitrogens, or she is not on antithyroid drugs or thyroxine. And patient underwent tubectomy 25 years back. Coming to menstrual and obstetric history, she attained menarche at the age of 13 years with regular cycles, and she has one child, which is a normal vaginal delivery. She attained menopause 5 years back. Family history is not contributory. Coming to personal history, she takes mixed diet. Her appetite is normal. She has regular bowel and bladder movements with no addictions and with adequate sleep. Summary of the case is a 50-year-old lady with a slow-growing painless swelling in front and lower right side of the neck since 4 years, with no evidence of pressure symptoms and no history suggestive of hyperthyroidism or hypothyroidism.
Please wait, sir.
Go back to your first slide, ma. Faculty, invited faculty, please take over, sir.
Chintamani sir.
Narayan sir, Kaliratnam sir, and
Yeah.
Uday.
Chintamani sir, you're muted, sir. Chintamani sir, you're muted.
Right.
You're
Sorry.
muted, sir.
Thank you. Yeah. Nice presentation. Good. And you covered up all aspects. I think it is a very usual problem, and you observe that lots of students describe bone swelling, joint jaundice, etc. as metastatic history. It's not that common with thyroid swellings and thyroid malignancies. So it is much easier to say that there is no history suggestive of distant metastasis, and then let the examiner ask you what exactly is that. Well, it's not common to have bone swellings or jaundice, because jaundice is not very early or common presentation. That is one. The rest is otherwise usually in a solitary thyroid swelling, by and large, straightforward. It's like writing on a dotted line. So not much of a confusion there. Secondly, diabetes mellitus is not a past history. Past history is something which has a connection with your present disease, and it was in the past and it's not continuing now. That's how we define past, isn't it?
Yes.
Diabetes once, mostly diabetes always. So you can always put it as a history of the patient is not a known diabetic or a known diabetic, depending upon whatever the case may be. The point was well taken that you're trying to talk about, and I'm glad you came out with the size straight away rather than beating around the bush. So we know that it has grown to twice the size nearly. And also the other thing that you mentioned about relating to what could be the possible etiologies, and no other neck swelling. I'm sure you were looking at or describing the lymph nodes, etc., if they were present. So by and large, straightforward. There is usually not a great issue, but we would be more interested in knowing the local features. Thyroid is known for that, so local features would include any. I don't know if you mentioned, maybe I missed it out, any features of local infiltration, like,
Pressure symptoms.
pressure symptoms are again a very vague scenario. It's mostly the infiltration. The thyroid cells could be small and yet infiltrate into recurrent laryngeal nerve, produce hoarseness. So that is what we would be more interested in knowing. Although your point is taken, it isn't a major problem, but I thought I'll bring it up, and not associated with fever and pain, right? That you're trying to rule out an inflammatory swelling. That point was well taken. Similarly, not associated with symptoms of hypo or hypothyroidism is very nice the way you brought it out. So rather than giving the laundry list of symptoms which present in a patient, I think by and large a good history. I just told you, I mean, bone swelling, jaundice is not metastasis. This isn't exactly how thyroid malignancies would manifest. So it's safer, like you said, not associated with symptoms of hypothyroidism. Similarly, not associated with any history suggestive of different metastasis. These are the points I thought would be important. Of course, pressure symptoms are important, but so are the local infiltrative features, which
ಕಟ್ ಮಾಡ್ಕೊತೀನಮ್ಮ ಯಾವ್ದು ಮೆತ್ತಿ ಕಟ್ ಫಸ್ಟ್ ಕಟ್ ಮಾಡ್ಬೋದು.
I've made my point. It is a straightforward case where she has brought out all the symptoms 1, 2, 3 in the order that they appear. So you can take over from there. Anybody else?
Professor Kaliratnam sir.
Yes, sir. Yes. Really, it's a nice presentation. She mentioned everything in short and sharp. Really, I appreciate her. The good presentation. That is more than sufficient for such a clear solitary thyroid nodule. We can discuss which following other symptoms, after inspection and all. So at present is well. Yeah.
All right. Dr.
Narayan sir.
Yes, Dr. Srinivasan, we can move.
Dr. Narayan sir, can we move on, sir? So you start, ma'am.
Yes, sir. Yes, sir. Yes, sir.
For now, go with the clinical examination.
Yes, sir.
Sagai sir, any comments?
Yeah, I just want to ask the candidate, how relevant is family history in a thyroid swelling? What are the various things can contribute to thyroid swelling? How is family history important?
Family history, there is a history of thyroid swellings in the first degree relatives which who underwent thyroidectomy. Because there are some familially associated thyroid swellings.
So what would be the familial neoplasms? Can you hear me?
Yes, sir.
What would be the familial neoplasms in thyroid?
The familial neoplasm could be a familially associated medullary carcinoma of thyroid. And papillary carcinoma of thyroid is also
Dr. Aparna, when you, if I may, when you talk about family history in any patient, I'm glad that point was brought up. I skipped it. Family history in thyroid swellings is very important, and there is nothing like non-significant, no similar complaints. That looks like a very lazy history.
yes.
It should be specific and focused, right? Thyroid could be part of a familial syndrome, as was rightly asked.
Yes.
It could be whether it's medullary or it could be part of an MEN. Or how do you know this is a thyroid swelling? It's lying in the thyroid region, so it could be another. There could be another reason for it. So take family history a little more. Put in a little bit of seriousness in it. It's a very common thing with students to say nothing significant, no similar complaints, but this is a lazy way to put it. You can score marks by mentioning no family history suggestive of any thyroid swellings. Then obviously you mentioned no features of endemic thyroid involvement in the family, etc. But in a solitary thyroid nodule, family history is given a lot more importance. Similarly, some kind of a therapy. You mentioned about radiations. Yes? In
Yes.
the childhood, you specified. What could be the significance of you highlighting that point?
If the patient has undergone a radiation exposure for lymphomas in the childhood, they might develop thyroid neoplasms in a period of 10 to 15 years later.
No, that's a very good point. And actually, a lot of people divide thyroid cancers into those post radiation exposure versus and those without. Right? It's an important history.
Yes.
Now, what kind of a radiation leads to thyroid malignancies? High dose or low dose?
High dose radiation, sir.
You see, high dose radiation in most cancers would ablate the gland. So you may not have cancers developing. The gland would actually get treated, right? If I was to cook the gland completely, it would be not left. So most people believe that both low and high dose can cause it, but low dose more commonly. And that low dose radiation is not commonly given these days for those benign conditions, which used to be earlier, where people are using it for adenoids, using it for pimples and scars, whatever. So low dose is more likely to lead to oncogenesis. High dose usually ablates, but that doesn't take it away completely. That high dose does not produce it. It can. Okay.
Yes.
So low dose is not given these days anyway. So any particular history that would be important to know for the low dose radiation, besides the lymphoma part you mentioned. If you don't know, you can
unmute, ma, unmute.
Besides that, the patient, if the
Okay, I'll answer that to save time. Low dose radiations can also come in zones or areas where patient is living and there is a low nuclear reactor, or you know about the Chernobyl incident. Yeah. So that is where radiation exposure becomes important. So you should know what you're asking. You should, because this would automatically be asked if you're mentioning. Similarly, you mentioned about the drug history. Am I right? Did you?
Yes. Yes, sir.
So you must have some reasons behind asking that history. There are some drugs that are goitrogenic.
Yes.
And their history becomes specific to the point. So a smarter way to put it would be no history of exposure to radiations, including low dose radiations, or the patient doesn't live in a nuclear exposure zone. Many people live close to the nuclear reactors. Within miles it happens, you know that. And the other thing, the second thing which you mentioned was about drugs. So don't just say no history of any intake of drugs, no history of taking goitrogenic drugs, but then be prepared to answer what are those drugs. Can you name any drug or drugs which can produce the thyroid swellings?
Lithium amidones.
Yes. So you can be scoring marks. The art of examination is you answer something and throw a question at the examiner which you want to answer again, so that you keep on scoring as it goes on. You getting my point?
Yes,
Each point that you're mentioning in the history has or should have some kind of a meaning. That was my submission.
Dr. Pan,
One more thing I would like to add in the family history is autoimmune thyroiditis. Very, very common in running in families is Hashimoto's thyroiditis. And they can act as a bed for neoplasms later on in life. So multinodular goiter and familial neoplasms, then autoimmune thyroiditis.
Important point. And Aparna, could you tell us the neoplasms that happen in the Hashimoto's thyroiditis?
The Hashimoto's, there can be thyroid lymphoma, papillary carcinoma, thyroid.
Excellent. So, you know, if you had mentioned it, the question would have come and you would have answered it and you would have got your 70% mark straight away. So learn that art, right? As Professor brought up, if you had mentioned them as 1, 2, 3, the questions would have followed and you would have scored easy, right? Dr. Srinivasan, can you move to examination? Or
yes, sir. Yes, sir. Yes, sir.
All right.
Nobody else.
May I just ask a question, please?
Please,
No,
please,
sir.
sir.
May I just? Dr. Aparna, why do you think a patient is getting lithium? Or why does the
Your,
patient get lithium?
so your voice is not clear. So I'm
No,
sorry.
your voice is not clear, sir. It's breaking. Sir, we can move to the sir, you can chip in anytime and ask.
Okay, I'll
I think you're logged in 2 devices. Yes, but you go to the clinical examination. Start.
Coming to the examination, a patient was examined in a well-lit room with adequate exposure in sitting posture after taking consent in the presence of a female attender. Patient was conscious, coherent, and cooperative, moderately built and moderately nourished. Her BMI is 22.4, and there is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. And patient was febrile. Her pulse rate was 88 beats per minute, which is normal in rate and rate, rhythm, and volume. Her blood pressure was 130 by 80 mm of mercury, and respiratory rate 16 per minute. This is the clinical picture. Coming to the local examination, a patient was examined in a well-lit room with adequate exposure and sitting posture from a front and back after taking consent in the presence of a female attendant. Coming to inspection, there was a single, approximately 6 into 8 centimeters ovoid swelling present in front and right side of the neck, with smooth surface, well-defined borders extending superiorly up to the level of thyroid cartilage and inferiorly 1 centimeters above the suprasternal notch, medially crossing the midline 1 centimeters towards the left side and laterally deep to the right sternocleidomastoid. In skin over the swelling appears normal. Swelling was moving up with deglutition. Trachea is deviated to the left side, and there are no other visible swellings noted in the neck. Coming to palpation, there is no local rise of temperature and no tenderness. Skin was pinchable over the swelling. There is 7 into 9 centimeters ovoid, firm, non-tender swelling present in front and right side of the neck with smooth surface and well-defined borders extending superiorly up to the level of thyroid cartilage, inferiorly 1 centimeters above the suprasternal notch, and medially crossing the midline 1 centimeters towards the left side, laterally deep to the right sternocleidomastoid. I was able to get below the swelling, that the lower border was visible. Swelling is deep to the deep cervical fascia, strap muscles in the right sternocleidomastoid muscle. Swelling is moving up with the deglutition and is mobile. There was no palpable thrill and there were no palpable swellings in the neck. Carotid pulsations were normally and in relation to the swelling. Trachea is deviated to the left side. On auscultation, trachea was deviated to the left side and no audible bruit where it was held over the swelling, heard over the swelling. There were no thyrotoxic signs. Coming to the systemic examination, her skull and spine were normal, muscular system is normal, cardiovascular system S1 and S2 are heard. There were no murmurs. Respiratory system, there was bilateral air intake present and no adventitious sounds with no focal neurological deficits, and paraabdomen is soft, non-tender, and there is no hepatomegaly. Coming to the summary, a 50-year-old lady with slow growing 7 to 9 centimeters ovoid, firm, non-tender swelling in the right lobe of thyroid with smooth surface and well-defined borders, with no evidence of pressure symptoms and with no features suggestive of hyperthyroidism or hypothyroidism, and no features suggestive of metastasis. My provisional diagnosis would be a non-toxic, a solitary thyroid nodule, likely benign with no pressure symptoms.
Right, Aparna. Can we move to the first slide, please, of general examination, so that I can take one at a time?
Yes.
Look, see, very nice. You made a good presentation. Your history was good, so is your examination going to be. BMI is a figure. It's not kg by meter square. So BMI is 22.4. You don't need to write this. This is a very common mistake, so I thought I'll let you know. And in the presence of a female attendant is not correct. It's a female chaperone, right? Whether it's a male or a female. Next. Next. Can you just move to the next? Yes. There is nothing, no rocket science here. We move next to the next one. This is beautifully shown. You've showed the the deglutition. And next. Now, please, in future, it will serve you well. I'm thinking when you're right, but I can make it even better. There's nothing like local examination. Yes. Local examination is too local. If you're examining a little ulcer in the region of thyroid, it's an examination of the head and neck or examination of the neck. Please understand that. Like it is examination of breast, examination of upper limbs, lower limbs, vascular system, etc. Right? Taking implied consent is a good idea. Now, you mentioned a single swelling, and everything you described is more or less fitting into the category of a thyroid swelling. So what I do normally like to do is, there is a visible swelling approximately 6 into 8 centimeters. And I like to mention here, for the benefit of all students, it's really liked by the examiner, if you mention the position in which you get the patient to examine, and where are you in this case, especially in thyroid. So I examine the patient in sitting position with me sitting in front at the level of the patient, inspecting from front and palpating mostly from behind except for trachea. Now this sends a message directly to the examiner that the candidate is sharper than the others. And then you describe all this, this jiggery-pokery of inferior here, medial here. On inspection can be asked by people, how were you so sure? So mention there's a swelling in the region of thyroid or a thyroid fossa, so that then the examiner can ask you the boundaries of thyroid fossa and you can answer that. Suprasternal arch, hyoid bone, sternomastoid, medial border, either side. The swelling lying there, moving and deglutition is taken as a thyroid swelling unless proven otherwise. So mentioning deep to sternomastoid, can a thyroid swelling ever be superficial to a sternomastoid? Can it be? Yes or no, Aparna?
It pushes the sternum.
Cannot be.
It is a nodular. Yes, it can be.
It has to be deep to it because the investing layer is going to cover the sternomastoid. So it doesn't need to be mentioned. It's to the right, up to this right medial border of the right sternomastoid. Next slide. I thought there were points, otherwise I'll miss. Now, skin over the swelling appears normal and swelling moves up with deglutition. Swelling moving on deglutition has to be up only because there's nothing else that moves. There's nothing that moves down on deglutition except food. So the swelling moves on deglutition. That is what is characteristic of a thyroid swelling, right? And trachea is deviated to the left side is beautifully mentioned, and it is visible in your picture also. Then skin pinchable over the swelling. Now you already mentioned the swelling is moving on deglutition. Now what is the plane of your swelling if it moves on deglutition?
It's deep to the deep
fascia, and that too much deeper. So these points become irrelevant. If a swelling is moving on deglutition, skin is pinchable. If you're trying to tell us it's fixed to the skin, it won't move on deglutition, right? And so maybe you just added that pinch and inch test, which is done for skin fixity. So you can, if at all you're very fussy about it, you can mention the swelling is not fixed to the skin, which will be, of course, superfluous after you mentioned that the swelling moves on deglutition, right? Next slide. This you again described beautifully here. So I think keep it to this point. Now swelling is deep to deep cervical fascia. Why would you like to mention that? Is there any swelling superficial to this fascia that will move on deglutition? Answer is no. Correct? So strap muscles, how do you see the strap muscles? You can't see them. Can you palpate them? You can't. And right sternomastoid, again, sternomastoid is invested by the investing layer of deep fascia. Strap muscles are also invested by it. So naturally it has to lie deep to it. So it doesn't need mention. Once you know the plane, it's the end of the story. Okay. Moving on deglutition, you mentioned before, and here also there is no problem. It moves on deglutition, it will move on deglutition then, whether you palpate or you inspect. It is mobile side to side, which is what you needed to mention. On deglutition, it is already moved up. There is no palpable thrill. Of course, you have your reason for that. No other palpable swellings, etc. So I thought some points were actually unnecessary and they don't make any sense. It only shows that you're confused about the whole idea, which you are not. If it is lying deep to deep, so if it has to lie deep to deep cervical fascia and to be invested in pretracheal fascia to be moving on deglutition. So it's got no business not to move, not to be deep to deep cervical fascia. So these points are actually unnecessary. Next, you mentioned that can you go to the next, please? No, before that, you mentioned that I can get below the swelling. Am I right? Somewhere?
Yes, sir. Yes.
That's a very important point, and you mentioned it very nicely also. So getting below the swelling is present. Present and absent is not getting below. So your statement is, I could get below the swelling,
Yes.
which clearly is to indicate that there is no retrosternal extension. And we obviously do not do percussion of manubrium and all that stuff these days, because that is very non-specific. Now, you mentioned about I haven't asked you any specific question. I'm just going by what you have presented. Next slide. Trachea is deviated to the left. You found on auscultation. You already found on palpation.
Yes.
Right? Auscultation, you'll hear it. That's okay. And no bruit heard. Is there any non-audible bruit that you think you know? What is bruit, Dr. Aparna?
The non-laminar flow of the blood, which produces sound. So we can auscultate.
It has to be audible. Then only you say that. No, there's nothing
Yes.
like no audible bruit. There is no bruit. Okay. And you mentioned that carotid pulsations are felt at the normal place. So where did you palpate for them?
And midway between the trachea and the anterior border sternocleidomastoid muscle and the upper 1/3 of the neck.
No, whenever you're asked a question about where do you palpate a pulse or a
Against the trans.
yes, so you have to mention against the bone. So against the C6 transverse process, Scheich-Hygnec's tubercle or carotid tubercle. And did you palpate simultaneously both sides, or you could do only on one side? Isn't that a regular question? You're glad to answer that. Can you?
On the one side, sir. One side at a time.
Why not both sides?
Because it causes a bradycardia and the patient might have a syncopal attack.
Why?
Because it stimulates the vasomotor centers and the vasovagal shock.
Baroreceptors there, you're right, absolutely. So do not say it cuts off the blood supply to the brain. It would be a wrong answer. Because the blood supply comes from elsewhere also. Is that okay?
Yes.
I thought I'll quickly mention these points because you don't have to pinch the skin. You don't have to mention that it is deep to deep fascia when it is moving on deglutition. And you couldn't be mentioning three things which are saying the same thing. Next slide, please. Now, if you're mentioning the systemic examination, remember, it has to be specific to the disease or the process or the organ that you're dealing with. So relating to thyroid, which one will come first? Of course, the CVS would come, although it's normal. And the rest can always follow. This is what I observed in your examination. There would be questions relating to examination, which I have not asked you, how to do whatever. And the points that you generally raise can indicate as to how matured you're about your understanding of the problem. Okay. And then, of course, the last slide where you summarized it beautifully. Can you? Yes. A 50-year lady. Elsewhere, you were mentioning a female, but a lady. That's a good way to mention. Give respect to the patient, you get it too. Now, you mentioned that the trachea is pushed to the left. Am I correct?
Yes, yes, sir.
So, how did you arrive at that? One is it's visibly shifted. And did you do any test to confirm it?
3-finger test, sir.
So, what is that test, Dr. Aparna?
Trials.
No, they are not they are not synonymous. They are not the same.
Yes, sir.
So one is an inspectory finding, the other one is a palpatory finding. So which one of the two is inspectory?
Inspector is trial sign.
The trail sign is prominent sternum, good. And how do you palpate is a 3-finger test. And suppose you're not able to get below the swelling, it's difficult, then you can palpate for the thyroid cartilage, or you can even auscultate, as you mentioned. There are some more questions, but I'm sure others will have questions, so I'll stop there. Over to you, Dr. Srinivas.
Aparna, you said that the superior border is the thyroid cartilage, isn't it?
Yes, sir.
Which border of the thyroid cartilage is the superior border? The thyroid cartilage is a broad structure, isn't it?
Yes, sir.
It's not like a hard bone. No?
Yes, sir.
It's a broad structure. So you have to say that it is the upper border of the thyroid cartilage.
Thyroid.
Just saying the thyroid cartilage will not suffice. You have to say it is upper border of the thyroid cartilage.
Yes.
And where did you auscultate the thyroid?
On the upper end of the swellings, on the upper pole.
Why at the upper pole?
Because the superior thyroid artery directly invests over the superior pole. So,
and where is the inferior thyroid artery?
Inferior thyroid artery will invest at the inferior pole, but before entering to the gland, it divides into branches and then enters the thyroid gland. So
you want to say inferior thyroid artery is at the lower pole?
yes.
Is it really at the lower pole or not?
Sir?
Inferior thyroid artery is situated at the lower pole of the thyroid? No, it is not at the lower pole of the thyroid. On the lower pole, there is only inferior thyroid veins are there. One or more veins may be there. But the artery is on the side. It comes behind the carotid sheath. So it is almost at, if you look anatomically, it is between upper 2/3 of the thyroid and 1/3 of the thyroid, lower 1/3. At that point, there is the inferior thyroid artery, and it is much deeper. Okay, that is why you always auscultate over the superior pole, because the superior thyroid artery is situated in that area and relatively it is superficial here. Okay. What did you examine the musculoskeletal system in this patient?
The proximal muscle weakness, the ability of the patient to stand up after sitting.
The squatting posture.
Yes, yes.
Then how did you test for the deep fascia here, that it is deep to the deep fascia? Then you said it is deep to the deep fascia.
Yes.
So how do you test for that?
By contracting the sternocleidomastoid muscle on the same side, so the swelling, the prominence decreases.
No, you said the deep fascia. I'm not asking the sternocleidomastoid. I'm asking about the deep fascia. Can you contract the deep fascia by any maneuver? I'm not sure about that.
No, sir.
You can contract the platysma.
Yes.
But I'm not sure about the deep fascia, whether you can contact that or not. And whatever the size of the thyroid swelling is there, it will be always deeper to the sternocleidomastoid. No? It can never go superficial to the sternocleidomastoid there. Okay. And which carotid did you feel in this patient? You said you felt the carotid pulsations.
Yes, sir.
Which carotid you have felt?
The right carotid.
How many carotids are there?
Right and left are common carotid.
No, there's a common carotid is there. There's
Yes.
external carotid is there. There's internal carotid is there. So which one you have felt?
A common carotid artery.
Okay. Can you feel the external carotid in the neck or not?
In the neck, no, sir.
Internal carotid?
No, sir.
So you cannot
Internal
feel the
carotid is
external
deep.
carotid as well as internal carotid. Both you cannot feel? Okay, against the C6, you can feel the common carotid.
Yes, yes, sir.
But if you go above that, you can feel the external carotid, but because there is no bone is there, that is why it is not very clearly felt. But if you have to feel the external carotid, it will felt in the neck. And if you have to feel the internal carotid, where you will feel that? If you have to feel the internal carotid, where can you feel it? You have to put your finger in the transverse fossa, which you will not like to put there. But if you have to feel the internal carotid, it has to be felt intraorally over the transverse fossa. Okay. Now you have made a diagnosis of solitary thyroid nodule, likely benign.
Yes,
So
sir.
what are the common causes of the solitary thyroid nodule?
It could be a colloid nodule, a colloid
Thyroid
cyst,
goiter, yes.
a benign adenoma.
Yes.
It could be a thyroid nodule in the thyroid in case of thyroiditis, or it could be a malignant nodule. A
So when
dominant
you are saying
nodule
here the
of
benign, what does that mean? Benign means you are talking of the, what is that benign means here? Are you talking the follicular neoplasm here?
yes, sir.
Or you are saying it's a colloid goiter there?
It could be a benign lesion, which could be a colloid nodule or a follicular adenoma. It could be a neoplastic or it could be a colloid nodule.
Okay.
Hello. Dr. Barna, I am Dr. Kalirathinam from Madurai.
Good evening.
So I want to add some more thing about the why we should auscultate in the superior. Number one is it is a direct branch. First and direct branch just more force on it, pressure. Superior thyroid artery is the first branch of the external carotid artery, a direct branch. So it is a high pressure, number one. And also it is coming and terminate anteriorly to the thyroid. It is not the posterior pole. Upper pole anteriorly placed and it divides inside the pole. So the artery will be solid until it enters into the thyroid gland. So these are the reasons the superior, we have to oscillate in the superior pole of the thyroid to get any increased sound. Then another one, everyone asked about the moving with decultation. Why the swelling moves with decultation? Can you explain this?
Yes, sir. Because the pretracheal fissure, which is condensed, form a Berry's ligament. So thyroid gland is attached to the trachea with this Berry's ligament. So when during deglutition, during the contraction of the inferior constrictor muscles, along with the trachea, the thyroid gland also moves with that.
Only that alone? Something else? See, can you enumerate the fascia, deep fascia in the neck?
Deep fascia
What
in
are
the neck,
layers?
it has investing layer, pretracheal fascia, and the prevertebral fascias.
Pretracheal, investing layer of deep fascia, pretracheal, prevertebral fascia,
Yes.
and also carotid sheath. These are all the
Yes.
neck fascia. So what is pretracheal fascia is split to enclose the thyroid gland. This is a very important thing. Not only Berry's ligament, the total pretracheal fascia, the superior pole split enclose anteriorly as well as posteriorly. But as usually the thyroid gland, what you are seeing anteriorly is less than the posterior enlargement because the posterior capsule is very weak. During our surgery, we can able to see there's a lot of posterior enlargement because of the deficient posterior capsule. So the pretracheal fascia split to enclose the thyroid gland as a bag. If you carry a bag, with the handles, just like that, it is holding, number one. Then all the superior arteries, all the arteries are attached to the moving structures. automatically it will be moving with decondition along with the your told Burris ligament. Okay. So these are the reason moves with decondition, not only the Burris ligament. Okay. So then sideways, what is the individual mobility of thyroid? Is it significant in this case or not significant?
It is significant, sir. We should clinically know about the local infiltration of the thyroid gland, thyroid swelling.
Usually it is mostly thyroid swelling is abutting to the trachea on either side. No, individual mobility it is not possible without moving the trachea because both the glands will be clasped around the trachea anteriorly. So it is impossible to move individual gland. If there is a large swelling like this, you can move a part of the swelling that is called treetop mobility. That is not the individual mobility. It doesn't give any information to our clinical information. Are you able to understand this?
Yes,
So
sir.
individual mobility, sometimes there may be small solitary nodule in the upper pole or anything. You can have a individual mobility within the thyroid gland. It is not that is called intrinsic mobility. Okay, that is entirely different from the mobility individual thyroid lobe. So intrinsic mobility is very important in the case of malignancy. When a solitary swelling, which was individually mobilized, movable on 3 weeks back, now it becomes immobile. The intrinsic mobility absent in this particular case significantly say that the tumor is infiltrating from the nodule to the thyroid tissue. Are you able to understand this?
Yes.
A solitary nodule which was freely mobile, having intrinsic mobility, that was absent after some time of period, that significantly says there's a malignant tumor or something else is fixed. Okay, that is very important thing. All other things are okay. Okay.
Can you go for the management part, sir?
1 second, sir. I would like to bring some points.
Please, sir. Please, sir.
Aparna, can you go to the first slide? I'll just run through the slides quickly and ask you questions,
Yes.
just for the benefit of the audience. Start from your first slide. Yeah. So why do you need a female attender, Aparna, when examining this patient? Normally, if you're a male and you're examining a female patient, then you need a chaperone. But
Yes.
if you're examining a female, I don't think seriously you need a female attender because the patient would like some privacy. Yeah.
Yes.
What has anemia got to do with thyroid? Any association you can find? Can you think about some conditions which can cause anemia and thyroid? If you can't just say no, we can, yeah. So one, you have a
Malnutrition where,
polyglandular deficiency.
along with iodine deficiency, there can be iron deficiency with iodine deficiency.
Yeah, more than that, it is called polyglandular deficiency. Patients with Hashimoto's thyroiditis can develop pernicious anemia and diabetes. It's very common to have pernicious anemia and Hashimoto's. It's called polyglandular, runs in families. Okay. What about clubbing? Can you get clubbing in a thing, thyroid?
In thyroid and like there can be thyroid acropathy where patient may have clubbing.
Very good. Thyroid. What about pedal edema?
Pedal edema is in primary thyrotoxicosis. There can be, it's not pedal edema. Mixed edema can be seen. Pretibial mixed edema.
But you can also get bilateral pitting pedal edema in a patient with thyroid disease.
Thyrotoxicosis.
Toxicosis with a high output failure.
Congestive cardiac
Go
failure.
to the next slide, please. Go to the next slide. Yeah. So if this patient, no, the previous one. Yeah, if this patient had a blood pressure of say 200 over 180, what can you correlate this now? A thyroid swelling with a blood pressure of 200 over 180. Can you correlate?
Yes, sir.
How?
A thyroid swelling, it can be a syndromic where patient can also have associated pheochromocytoma where she is having a persistent
So it could be
hypertension.
part of an MEN.
Means,
What about the pulse rate? What is its significance in a thyroid patient?
if the patient is in a toxic state, the patient might have a basal pulse rate and a higher normal levels.
What is the commonest rhythm abnormality in toxicosis? What can they go in for?
Patients might have extra systoles.
Atrial fibrillation. One of the commonest thing is atrial fibrillation as a toxic. To overcome the anxiety when you're examining and the patient has got tachycardia, in a thyroid toxicosis, what do you normally advocate? Why do they have tachycardia? To overcome the sympathetic component, what would you advise if it's a thyrotoxic and you want to see the response to your treatment? You're given beta blockers. What would you check for? The sleeping pulse rate, isn't it? The anxiety component is removed, and that will give you a better determination of the toxic component. Yeah, go to the next slide, please. Yeah, next one. Yeah. Again, you put the female attender in the first thing. Now, when you say here, instead of front, I would prefer anterior aspect of the neck or any swelling in the neck. You can say which triangle it belongs to, carotid triangle or anterior triangle, posterior triangle, because front of the neck doesn't mean anything. Your chain can be in front of your neck. Okay. And right side of this is good with well-defined borders. And now, next, laterally deep to, I think sir already pointed out, laterally deep to the on inspection, you can't make whether it's deep or superficial to the sternomastoid, isn't it? So that comment probably. So you say extends up to the anterior border of the sternomastoid or posterior border of the sternomastoid. Don't comment on whether it's superficial or deep. Now, if you see thyroid swelling with a sinus or a fistula, what is most likely, a fistula or a sinus? Which swelling commonly, sorry?
Yes, sir, can please repeat the question?
When you say the skin is or the swelling appears normal, but you see a small puckered scar over the swelling in the neck, anterior aspect of the neck,
yes, sir.
which moves on deglutition.
Yes,
what would you think of, whether it's a sinus or a fistula?
I would think of a fistula, sir.
What fistula would you think of?
Thyroglossal fistula.
Fistula. And is it congenital or acquired?
It is acquired, sir. Congenital thyroglossal fistula is acquired.
Fist always is acquired. Following an incision and drainage, people mistake it for, say, infected swelling. What other additional clinical sign will you have in a thyroglossal fistula?
In case of fistula, the swelling ongoing with deglutition. In addition to that, it moves with protrusion of tongue. Protrusion
of the tongue. Okay. Now, trachea is deviated. Again, you corrected yourself. Trail sign. Here is the prominence of the sternomastoid. You corrected yourself. That's good. Okay. Now, go to the next slide, please.
Sir, we have been asked to close in 10 minutes, sir, please.
Sure, sir.
We'll go for the management, sir.
Sure, sir.
If you don't mind.
No problem, no problem.
Sir, with your permission of the faculties, can we go for the management? So, Aparna, now you have told your diagnosis.
Hello.
How will you proceed further with the management?
For the management, I would go with the quadruple assessment of the thyroid.
Yeah, you come to that slide. Come.
Yes.
Yeah, you keep proceeding it.
Yes.
So you want to do an ultrasound of the neck?
I will go. Yes, sir. With the quadruple assessment after clinical exam, history and clinical examination, I would like to go with biochemical examination, sir. First, I will go with the thyroid function test and check for TSH, T3, and T4 levels of the patient.
So, what is the quadruple exam? One is clinical, two is biochemical, three is.
3 is radiological, and 4 is histological examination. Cytology.
Aparna, is that quadruple examination? You see, the basic approach to any thyroid swelling is triple test.
Assessment.
So triple test includes good quality history. Many points have been covered, along with a good examination, followed by high resolution ultrasound imaging using thyroid staging and grading, followed by FNAC after doing the thyroid functions to make sure that you're not doing it in a thyroid patient. And the fourth component, if you want to add quadruple, is the gene panel which you run. So that is not done frequently unless it's a familial or it's a malignancy in a hereditary setup, right?
Yes.
So how do you grade the thyroids? What are the components? If you do not know, you can always read it up. It's not a rocket science, and don't get confused about it. If you do not know, read it up. It's useful.
Yes.
Why should you do thyroid function test before FNAC?
To know the toxic status of the patient. So,
What goes wrong if you do it in a toxic patient?
in a toxic patient, the thyroid gland would be vascular. So on doing FNAC, there might be bleeding. So.
No, but that is a very usual notion. There are three parts to the problem. If you do FNAC in a toxic patient, which also any FNAC, any core biopsy students should be image guided these days. There's nothing like a blind needle in. Why? Because you want to hit the right place, correct?
Yes.
On ultrasound, I'll just quickly tell you, taller than wide, halo sign, and also the necrotic areas and heteroechoic presence. You can see many other features. So I'm not going there. And when you're doing the FNA, if you do it in a toxic patient, one is the risk of pushing the patient to thyroid storm. The second is, of course, hemorrhage is a possibility. And thirdly, which is important and often missed, is a false positive for malignancy. Because you get lots of atypia, proliferative cells, so you may get a wrong idea of the diagnosis, correct?
Yes.
So these are 4 reasons why you need to do thyroid function. And
So
you do the panel in select cases only. You mentioned I did not interfere at that time, the hereditary scenario. You mentioned papillary also can have some genetic basis. Could you tell us about the gene that you're referring to? Well, it's all clinical case. It doesn't really make a difference, but you should know about it. A whole long laundry list, but importantly, people look at 2 or 3 genes. One of them is related even to the aggressiveness of the disease. I've given you a hint. Which one is that?
P53s.
P53 is the subset.
Anaplast.
And any other gene or any other panel which will tell you about whether it's an aggressive cancer or it is a non-aggressive cancer, one which can connect with your, response to radioactive iodine or not, or it is radioactive iodine resistant. You keep thinking about it. You can always answer later on. I won't push you into it, but if you know it, you get more marks for it.
Yes.
Getting what I'm saying?
Yes, sir.
You are usually fine with whatever you mentioned so far. And when you mention ultrasound of the neck, it has to be focused, high resolution ultrasound. Can you make ultrasound even better if you want to get some good outcome?
Ultrasound with Dopplers.
How would that help?
Vascularity of the nodules.
Or you can also do elastography, which adds to, that has got grades of it also. Okay, so ultrasound can give you a lot of information, and then FNAC would add to it. And you're otherwise, as far as I'm concerned, fine with the triple test. Quadruple is done only if you are running a gene panel. It's expensive, not really needed in all the situations, and you cannot be doing it for all the genes. It doesn't make a huge amount of difference. At the end, you can answer, which I asked you. I'm not trying to push you into it. The radioactive iodine resistant tumors, which have that gene expression, they count towards aggressiveness. Can you remember? Have you heard of BRAF?
Yes, sir.
BRAF mutation. So you can look in specific cases. Okay.
Yes.
And how do you grade FNAC? I'll just take 2 minutes and wind up.
Standard is 5, sir. Like the one C cystic, or non-neoplastic, follicular neoplastic.
I'll make it easier for you. There is a Bethesda grading. Which is the other one?
Yes.
The one you were describing, what is that called?
Stand.
You can give it
The
your name.
names.
It doesn't matter. There's nothing in the names. Importantly, understand that grading makes the difference today. To simply call it a colloid cyst or to say it's a colloid goiter doesn't make any sense. It's non-specific, right? So basically, when you are asked a question, how will you proceed? You could have done investigations to confirm the diagnosis, to support the diagnosis, to stage it if it is a cancer, and to treat. To confirm the diagnosis, you will do the triple test, and you mentioned that beautifully. And to stage, if only cancer where you require the staging, what would you do to treat? What important investigations?
Before going with treatment, other investigations once knowing that the patient is euthyroid, that is the patient is not toxic, after going guided FNS, then
this you've already
with,
done.
yes,
Now you're basically doing investigations to take
to know the diagnosis.
So you should know the diagnosis, which I mentioned as confirmation. By doing the triple test, you should have the diagnosis, right? Yes or no?
Yes, sir.
So what's the FNFC finding?
FNS finding is a colloid cyst, sir.
Okay, you got to the colloid finding. Now, sir is asking, you have finished your clinical, the third examination. Now, what is your next plan of management?
See, very correctly, Dr. Srinivasan. Here it shows Bethesda grade 2.
Yes.
College has done a smart job of it. He has given you a direct hint that it's a benign condition. So what are you going to do for this case? That's what he's asking.
In a benign condition, when the nodule is less than 4 centimeters, we can actually go with conservative management, asking the patient to come for regular follow-ups. The patient is not having any pressure symptoms or any cosmetic constraint.
Okay.
Hello. Dr. Varna, this much swelling, do you want a conservative? Or do you expect
in my case,
it's cosmetic?
yes.
This case.
In
this case,
what?
huge swelling, you know.
Yes, sir.
This cosmetic.
Yes, sir.
And all other things. Even it is benign, you know.
Yes.
Obviously, a large swelling, it may not be a conservative. Okay. What type of surgery you want to do in this case?
In this case, I would like to go with hemithyroidectomy.
Suppose you're doing hemithyroidectomy.
Yes.
If biopsy comes as a papillary carcinoma, what will you do next?
Once the histopathology report comes, and I would go with completion thyroidectomy, sir.
Straight away, you will go for completion thyroidectomy, or do you want to some?
I will go with the staging of the disease by going with the whole body radio iodine scan, sir.
Any other test?
But before doing that radio iodine scan, it's necessary to go with the completion thyroidectomy.
No. Thyroglobulin and thyroglobulin antibodies. Is there any role for that? To have a diagnosis of recurrence or something else. So thyroglobulin and thyroglobulin antibodies is very important. If a papillary carcinoma comes, if it is more than any 10 nanogram, then you have to go for surgery. Recurrence denotes a recurrence or tumor in the opposite side. So also, okay. Then you have to do all other investigation, not straight away. Then molecular examination also you can do. As Shah said, you know, genetic gene expert tests. Then you can accordingly you can plan for completion thyroidectomy, or you can observe. It is positive, but to go for completion thyroidectomy, or otherwise you can wait and watch, depending on the molecular biology. Okay. So this is for this benign tumor. It is hemithyroidectomy is the choice. Conservative. Suppose if it is completely cystic, less than 2 centimeters, you can go for aspiration until 3 times. If it is not subsided, once again you have to go for hemithyroidectomy. Since it is a tumor is more than 2 centimeters as well as huge, then you can definitely go for hemithyroidectomy. Okay.
Aparna, before you go for the thyroidectomy in this patient, what are the special investigations you are going to do?
I would go with direct laryngoscopy, sir.
Direct laryngoscopy. How you do
Indirect.
direct laryngoscopy?
Direct or indirect?
Clinically, you will do indirect laryngoscopy, sir.
Who does the direct laryngoscopy usually?
Sir,
Who does the direct laryngoscopy usually?
direct laryngoscopy is done by ENT surgeons.
No, they do the indirect one. No? But nowadays they can do it with the fiber optic, that is okay. But otherwise, who does that direct laryngoscopy? They usually do the indirect one with the mirror.
Yes, sir.
So who does the direct laryngoscopy? It is by the anesthetist.
Yes.
When the patient is on the table,
Yes, sir.
he sees directly there. No? So
Yes.
that is the direct laryngoscopy. No, you can do it with a fiber optic, that is okay.
Yes.
So that is one. What else you want to do before you plan for the surgery?
We'll go with X-ray of the neck, sir. Soft tissue X-ray of the neck, sir. AP and lateral views to know the
Why you want to do the AP and why you want to do the lateral?
AP to know the deviation of the trachea, sir, and lateral view to know the luminal volume of the trachea, sir. To know it is for the anesthesia, sir, for the intubation of the patient.
So it is only for the anesthetist or it's also for the surgeon also?
To even to know about the retrosternal goiters also.
Now, how these two X-rays are helpful to the surgeon and how they are helpful to the anesthetist?
The tracheal deviation, the lumen of the trachea will help the anesthetist, sir. So I don't, for the surgeon, I don't have that idea. So,
No, normally you will think trachea in the central area, isn't it?
yes, sir.
But it is lying far away. So you can definitely damage the rectal engine nerve, they move along with the trachea.
Yes, sir.
Okay, so you will damage the rectal engine nerve, you will damage the trachea also.
Yes, sir.
And lateral view for the surgeon, why? What is the importance of that lateral view for the surgeon?
Calcifications.
No, if there is a tracheomalacia is there.
Yes.
So as soon as you do the total thyroidectomy, the support goes and the trachea will collapse. So you have to keep the endotracheal intubation or even the tracheostomy for that patient.
Yes.
Okay. So it is both for the surgeon as well as for the anesthetist here.
Yes.
Okay.
Yes.
Right.
Right.
Now, what is the importance of fiber optic to assess the vocal cord? Preoperative assessment of vocal cord. What's the reason for that? Why you are
Like to know the preoperative, if there is any occult vocal cord paralysis.
yes. Less than
Put in
2%
one
of the
word,
people may have
People may have
asymptomatic
asymptomatic vocal cord paralysis.
paralysis will be there. 2% of the population. Usually it will be on the right side. Okay, for that, and also it is a medical legal purpose.
Recorded for
assess
medical legal
post-operative.
purpose. Recorded for medical legal purpose in this era. Okay.
And more importantly, it is not the ideal. It is the voice quality assessment, because even if the nerve is
Ultrasound.
fine, so this is what has been added, and you should know that.
Percutaneous ultrasound of the larynx.
And don't follow the Google all the time. They may give you wrong information. If you read if you want to read about thyroid, you should read books that mention about very clear, crisp ideas. Okay. So when you have got a decision to make on the minimum surgery or minimum biopsy for thyroid, it's not FNAC, it is hemithyroidectomy. So therefore, whenever you have some doubt, those terms like follicular neoplasm or papillary variety of follicular, they are not commonly used. We use Bethesda only these days, right? Hemithyroidectomy is the minimum biopsy, like superficial parotoidectomy is the minimum biopsy for parotid. So you should be clear on that part. And about the quadruple test, there are ways to look at it. Simple books otherwise would describe it. The fourth part, which has been added, the rest are obviously a part of the triple test, is the gene panel, which you do for genetic cancers. Otherwise, there will be fifth test, which is not really necessary. Thank you.
Dr. Uday Kumar, Professor Uday sir, would you like to ask any questions or give your comments, sir?
Yes, I am having few comments.
Yes, sir, please.
The first thing is that she mentioned that thyrotoxic signs in the neck examination. Instead of that, she should mention it in the general examination. That is the first thing I would like to add. Second thing, I saw that video what she showed, where the exposure of the patient was not only the neck. Why? Any reason, Dr. Aparna?
So could you repeat the question?
No. This exposure of the patient was not only confined to the neck. It was little more, and the upper chest was exposed. Any specific reason for it? Yes, I will answer the question. Actually, it should be exposed upper chest, particularly in a case where we are expecting it to be a retrosternal goiter, and there is some signs you are going to elicit, where that is particularly the Pemberton sign, where you wanted to see the dilated veins over the chest. So that is the actually reason. But in this patient, it was actually not necessary to expose, because being a female patient and where you are not expecting patient to be having a retrosternal goiter. Third thing I would like to add, that you must know what are the different, it is for the benefit of all the pages, you must know what are the different methods of palpating the thyroid gland. That is the standard method and Lahey's method. Particularly the Lahey's method, what are the objectives of all these three? Standard, Lahey's and Kreil's method. You must know the objective of doing these examination. That is one another thing I would like to add. Fourth thing, you have not mentioned regarding the rest of the gland. You have mentioned regarding the palpable nodule, but you should mention about the rest of the gland, whether it is palpable or not palpable, because it is having its own importance before we come to a diagnosis that it is a solitary thyroid nodule. Fourth thing I would like to add, that in ultrasonography you have mentioned regarding this lesion, but there are two lesions, one in the same lobe as well as in the opposite lobe. I don't know why you have ignored those two ultrasonography findings while in the management of the patient, because it will make a great difference, right from hemithyrectomy to it will go to the certain, or we have to evaluate these two lesions. That is the another important point I would like to make uh, make me noticed by you. These are a few observations what I feel, but overall it was very good presentation, as well as most of the faculties have very critically appraised it. Thank you.
Thank you, Professor Uday sir. Dr. Aparna, do you have any questions or comments, or you have any queries to be clarified with the eminent national faculty?
So I have a doubt regarding the quadruple assessment, sir. Which is,
Yeah, please ask.
like the fourth component which is added, sir.
Yeah, I'll make it easy for you, Aparna. You don't get confused. If you look at the triple test, which is given in your old textbooks, it is thorough history, clinical examination. Second, high resolution ultrasound, not a vague imaging, right, including Doppler. And third is FNAC after doing thyroid function tests. So some people take thyroid function tests as the third one, and they make FNAC, which is image guided, as the fourth. Correct? Now, if you read the our own chapter in Southeast Asian endocrine book, we've written on the thyroid cancer. So that is, in the context of the cancer, quadruple test includes the fourth component as the gene panel. There's nothing much in it. You don't have to get worked up on it. Even if you don't mention triple test or quadruple, it doesn't make a difference. But you should be able to mention the test. That is more important. So don't get confused. So if you click on Google, you may find an, with 3 or 4 types of answers there. But I'm giving you one which will help you. That is, the idea is good history, examination, followed by imaging, followed by FNAC after doing thyroid function test, which I've explained why. And in hereditary cases, we may do the gene panel. Gene panel is not done as a routine, especially these days. BRAF mutation for papillary is taken as a very important predictor of doing not only total thyroidectomy, but also central neck dissection, which is a prophylactic central neck dissection in negative nodes. I didn't go there because that was not getting the point. So if you are looking at BRAF mutation, these are cancers which have a very high aggressiveness grade, because they do not respond to radioactive iodine. Therefore, you'll have to do thyroid nodule. Point. So this is that context. Okay, I have just kept it brief. So you should understand there's more to it than meets the eye. So it is not about 3 or 4. You can do 15 of them. But the important thing is that you should know what all does it include. So when you're doing an FNAC, you will always have to do a thyroid profile. So that doesn't qualify as one extra test, according to some people. Some people like to mention these 4 as quadruple. But the standard approach is triple test in a benign scenario, right?
Yes. Thank you.
Faculty, other faculty would like to give your comments. Can we move to the next case now?
Yes, sir. Nice presentation. Yes, we can move for next case.
Thank you, Dr. Aparna, and I give my warm regards to Professor Sadgunachari sir and Professor Sridhar sir for permitting to be presenting a case here. And you are welcome to stay back. We move on to the next case. Dr. Irene Matthew, are you with us?
Yes, sir.
Fine. You can switch on your video, start your PPT. Introduce yourself, your unit chief, your department head, and start your presentation. Good luck and best wishes for your presentation.
Thank you, sir.
Yes, you are good to go. Good luck.
Good evening, all. I'm Dr. Irene from Malabar Medical College, presenting a case of breast lump under the guidance of Professor Ajesh Gopal and our head of department, Professor N.P. Shashi. So it's a 49 presenting complaints. It's a 49-year-old housewife. She is from Purakkad. It's in Kerala. Came with complaining of lump in left breast since 3 years, nipple retraction since 4 months, ulceration since 2 weeks. Come to the history of present illness. She came with complaining of lump in left breast since 3 years, which is insidious in onset and gradually increase in size over the years and rapid increase in the size for the last 3 months without any pain. There is a history of nipple retraction since 4 months, and she noticed a nodule in the same breast 1 year back, which got ruptured and has now came with an ulcer since last 2 weeks with blood-stained discharges from the ulcer. No history of any nipple discharge, no history of fever, no history of any weight loss or loss of appetite, no history of any bony pain, chronic cough, hemoptysis, jaundice, headache, vomiting, seizure, or any other swelling in the opposite breast or axilla. No history of edema in the upper limb. Past history, no history of similar complaints, no history of any hormonal treatment or radiation exposure, no history of diabetes mellitus, hypertension, pulmonary TB, bronchial asthma, coronary heart disease, no history of any surgeries in the past. Personal history, diet mix with good appetite, normal bowel and bladder habits with adequate sleep. Her menstrual and obstetric history, she attained menarche at the age of 13 years with regular 4-day cycles with normal flow, married at the age of 30 years with obstetric score of P1, L1 and A0. Last childbirth 31 years back. She had full-term normal vaginal delivery and breastfed for 3 years. Her last menstrual period was 11/4/2023. Family history, no history of any malignancy related, first degree relatives like breast, uterus, colon, thyroid, or pancreas. Summary, 49-year-old perimenopausal woman who had first childbirth after 30 years, presented with complaining of lump in left breast since last 3 years, with history of rapid increase in the size since last 2 months, associated with nipple retraction since last 4 months, and had an ulcer since 2 weeks without any symptoms suggestive of metastasis, no history of menstrual irregularity or abortion.
So Chintamani sir, you are muted, sir.
No, I was not speaking. I was waiting.
I'm sorry. I'm sorry.
Right. So can you go to the first slide, please? A good history. I thought I'll just look at, when you history of present, I think it was before that. This must be the second slide, right? Presenting complaints you mentioned.
Go to the first slide, Irene.
So 49-year-old housewife, and this age becomes important. So we'll take one at a time. lump in the left breast for the last 3 years. Since means a fixed date. So it's a safe, better term is for the last 3 years because you don't know really. And nipple retraction for the last 4 months, an ulceration over the lump or it's not
Ulceration
over
over the lump.
That would be actually 49 years lady with lump in the left breast for the last 3 years, associated with nipple retraction for the last 4 months, and ulceration over the lump for the last 2 weeks. This is how it happens. Next slide. Now, this is more or less the history that you gave in the history of present illness, that it has rapidly started increasing in the last few months without any pain. Now, why do you want to mention without any pain here? If there's no pain, why should you mention it? Why is it important? So it is just like that you add it. So basically the patient had an insidious, a gradual progression, and it has suddenly started increasing for the last 3 months. Next slide. Nipple retraction for the last 4 months, and she noticed a nodule in the same breast 1 year back, which got ruptured. These are terms that we don't use. Nodules don't rupture, they ulcerate.
Okay, sir.
So they ulcerated through skin, and for the last 2 weeks, there is a blood stain discharge from ulcer. Well, I'm trying to make something of it. It is what you're trying to tell us is there was a lump for a long time, which suddenly started growing, and then it ulcerated, and now it is discharging. There is bloody discharge, right? Is that what you're saying?
Yes,
okay.
Sir.
I'm putting a history in perspective. Next slide. No history of nipple discharge, no history of fever, no history of any weight loss. Now, when you say no history of any weight loss, maybe she lost 1 kg. So you would like to mention no history of any significant weight
loss.
So that you get a question, some examiner may ask you, what is a significant weight loss? And what is it, by the way? What is significant weight loss?
Unintentional weight loss for the past 10% loss of weight for the 6 months.
Now, more than 10% of weight loss, unintended weight loss, as you correctly said, in less than 6 months, right?
Yes, sir.
And now the entire list of pain, bony pain, chronic cough, hemoptysis, jaundice, we discussed in the previous case also, you could have corrected it. There is no history suggestive of distant metastasis, and let the examiner ask you what that history would be. And there is no history of edema or the swelling of the upper limb. Correct?
Yes,
next
sir.
slide. No, that's okay. Past history. Now, what do you mean by similar complaints?
Any other similar swelling in the breast?
Please mention.
Not other.
This is a very vague statement. I mentioned in the previous case also. There's no history of lumps in the past or any breast-related disorder in the past. So it will be more focused. Correct?
Okay, sir.
Now, patient doesn't know her problem, so she cannot be telling you exactly what you want looking for. No history of receiving any hormonal treatment. What would that be for?
Hormonal replacement therapy is a risk factor.
Yeah, yes, I'm so glad you know it. So you could have straight away mentioned no history of receiving HRT or any radiational exposure in the childhood.
Childhood.
When we are discussing the radiational exposure, usually we follow the formula of 20, less than 20 years of age and less than 20 centigrades or centigrades exposure. Low dose, low and a younger age. And past history, as I mentioned in the previous case also, it's diabetes, hypertension, they are not past history. Tuberculosis can be. So there is no history of, patient is not a known diabetic, not hypertensive. There is no history of pulmonary tuberculosis or bronchial asthma or any coronary artery disease, and no history of any surgery in the past. I'm just correcting what you mentioned. You've done a good job. I'm just making it better, so don't feel bad about it. Next slide. Now, personal history is important, and you covered it nicely. Next slide. Now, this is an important history for us in breast lumps and breast cancers. Menarche, 13 years, regular 4 cycles with normal flow. What is its significance?
Early menarche is a risk factor for the breast cancer.
And married at 30 years, what is the significance of this?
Late marriage and followed by the childbirth will be late.
So basically, you're looking at, the high risk history. correct? We call
Yes,
it a high risk history, isn't it? And when you're saying menarche, early menarche, how does that cause the cancer?
Early exposure to the estrogen, because first cycles will be anovulatory cycles because of the underdeveloped hypopituitary ovarian axis.
Brilliant, absolutely. I mean, this would be, these are non-ovulatory cycles. So high estrogen exposure, that is what it is going to lead to. Breastfed for 3 years and LMPs 11-4-2023. And how do you explain this? Is she premenopausal, is she perimenopausal or postmenopausal, according to your presentation?
Perimenopause.
Well, I agree with you. And how much period is taken as peri?
I don't know, sir.
Think about it and we'll discuss it at the end. I don't want to delay and the others may be asking you questions. Next slide. Obstetrics history was not very elaborate, but important. Any role of miscarriages, abortions?
Abortion is a risk factor for breast cancer because of the unopposed rejection.
Very nice, very good. So that can come here. So when you're mentioning, when you already know it, might as well score for it. So
Already scored, sir.
yeah, so I mean, okay. So you can always score using it. So you mentioned A0, so you
Yes,
should mention that. And actually, usually when you're presenting in a surgical scenario, it is always good to mention it loud and clear so that the examiner knows what you're saying. Next slide, please. Family history you've taken very nicely. Why do you want to ask the history of colon, thyroid, pancreas?
BRCA-related gene mutation.
So a smart way to put it is, no history suggestive of any BRCA1 or BRCA2 related.
BRCA2 related.
So then the examiner may ask you, what are those? Then you can cover it up. Now, what all did you ask? Is it in the, you mentioned first degree relatives. It's a very
Yes.
non-specific term. All of them, mother, father, uncles, who else?
Parents and children, sir.
So
First degree.
here, when you mention breast, uterus, colon, thyroid, pancreas, you've still not completed that list. So it's safer to say BRCA1, BRCA2, because male breast cancer and prostate cancer also
Prostate
come.
cancer also.
So that would automatically be covered if you mention no history or high risk. I mean, that would be covered with the BRCA1, BRCA2 mutation. And your summary now. So you mentioned it beautifully here. And it is already pointing towards a particular impression or diagnosis. Dr. Kanagavel, history part,
Yeah.
I'll go through the slides. You can take over from here, please.
Sure.
Shall we move to examination or anybody?
Please. We have other faculty. I will quickly ask, sir, Dr. Kali Ratnam, sir, Dr. Uday, and Dr. CDN, sir. Would you like to ask any questions here?
No, you can go examination straight away because time is going,
Kanna, sir?
Aparna,
already.
you are asking the family history.
Yes, sir.
Okay. Mother had a breast cancer. What are you going to ask?
The age at her presentation, a diagnosis.
And the two most important things you have to ask is whether it was in the premenopausal or postmenopausal, or whether it was the unilateral or it was the bilateral. Because if a mother had in the premenopausal bilateral breast cancer, that has got the highest chance of having the breast cancer. Okay, these are two things you are going to ask. Now, can you tell what are the various absolute risk factors for the breast cancer?
There is a modifiable and non-modifiable risk factors.
Right.
Age, nulliparity,
Yes.
cumulative breastfeeding years.
So, which one you are telling? Is it the modifiable or non-modifiable? Because you cannot modify the age.
Non-modifiable.
Yeah.
Age,
Yes.
woman,
Yes.
previous family history of breast cancer.
Good.
Early menarche, late menopause.
If you look at the absolute risk factors or what are relatively what are called as the non-modifiable risk factors. They are basically the age of the patient, sex, family history, if the patient had a breast cancer on one side, any benign breast disease which makes it an absolute risk factor.
Yes, sir. Atypical breast lesions have a
Atypical
risk
ductal hyperplasia, or in situ carcinomas, and the BRCA gene positive.
BRCA related.
Yeah, so these are all the absolute risk factors, while all others which are there, like nulliparity,
Obesity, alcohol,
obesity,
smoking.
alcoholism, smoking, HRT, and all those, they are all just the
Modified.
relative. Yeah, they are relative risk factors. So, what is the difference between absolute and the relative one? When you say it's the absolute risk factor, and when do you say it is a relative risk factor? If the risk is more than 2 times, it is the absolute one.
Okay.
If it is less than 2 times is there, then it is the relative risk factor.
Relative.
And can you tell, Aparna, how much time does it take to make a 1 centimeter palpable breast lump? Like if somebody lady had a breast cancer of 1 centimeter size, how long she is having that?
5 times doubling time.
Sorry?
5 times the doubling time.
5 times the doubling time. So what is the doubling time? For the breast cancer?
5 years.
No, it can't be 5 years. Okay, it is 80 to 100 days.
Okay.
And it takes around 30 doublings.
30.
And those 30 doublings which are there, it has to be there for 5 years.
Okay.
So a palpable 1 centimeter lump which is there means the lady had a mutation 5 years back. And when can it metastasize? It is said that it's around 22nd, 23rd doubling which is there. So much before it becomes the 1 centimeter palpable tumor, it can metastasize. And that is why all those concepts which has come. You know what are the various concepts of spread of the disease for the breast cancer? What is the Fisher concept? What is the Halstead concept? What is the spectrum concept?
Halstead concept is a systemic, breast cancer is a local disease.
No, Halstead concept is?
Local recurrent.
It is loco, yes. It is the loco-regional disease.
Loco-regional recurrent.
And Fisher is
one is systemic.
Systemic one.
Systemic.
And both are not correct. That is why the third concept, which is there, the spectrum concept, which is there. So it can have the loco-regional spread
Loco-regional as well as systemic.
Okay.
Aparna, Dr. Khanna just mentioned about the risk factors, and he mentioned in situ cancers, right?
Yes, sir.
One in situ is cancer itself, so you cannot call that a risk factor. Which in situ is a high risk factor?
Ductal carcinoma.
No, ductal carcinoma is cancer. You can't, ductal carcinoma,
Carcinoma in situ.
lobular carcinoma in situ. So that is what you should understand. The other one is atypical duct hyperplasia and also sclerosing adenosis and scars, radial scars. That's what you look at, right? So
Yes.
the risk modifiable, in other words. And Halstedian concept, as very rightly mentioned, was very old concept of sequential spread. So predictable echelon-based spread. Fisher's concept, which came in 70s, was that it's a systemic disease to begin with. And we have taken a middle path, but by and large, Fisher's concept is what is followed. That's why you put the patient on systemic therapy in the form of neoadjuvant disease. Right? Can we move to examination, Dr. Khanna?
Sir, most welcome, sir. Most welcome.
Please proceed, Dr. Aparna, to your examination.
Come to general examination. Patient is conscious, oriented, and cooperative. Her performance score by Karnowski is 100. She is moderately built and nourished. Febrile. Pulse rate is 76 per minute in radial arm. There is no normal in volume and character. There is no radio or radiofemoral delay. BP is 140 per 70 millimeter mercury in right arm, sitting position. Respiratory rate is 18 per minute, 18 cycles per minute. Saturation is 98% in room air. No pallor, icterus, cyanosis, clubbing, bilateral pedal edema or generalized lymphadenopathy. Examination of both breasts. It was done in a well-lit room. She is examined in sitting position, leaning forward position, arms by the side raised above the head and pressed against the waist. On inspection, left breast pulled upwards. There is a fullness present in the inner quadrant of left breast. Retraction of nipple present. Pudiorange present over the inner aspect of the left breast. Shyness present over the skin. This is a picture. And an ulcer of 2 into 1 centimeter present at 6 o'clock position, which is 3 centimeter away from the nipple areolar complex. Margin is raised. Floor contains unhealthy granulation tissue. The surrounding area is edematous. There is a blood stain discharged from the ulcer bed. Left axilla, no visible swelling present. Left arm, no edema present. Right breast and axilla appears normal. On palpation, there is no local rise of temperature or tenderness. A well-defined lump of 8 into 7 centimeter present in the left breast, 6 to 2 o'clock position, involving retroareolar region, hard in consistency, skin not pinchable, and the lump is moved along with breast tissue, not fixed to the underlying structure or chest wall. An ulcer of 2 into 1 centimeter present over the 6 o'clock position, non-tender, margins raised, bleeds on touch, and base of the ulcer contain unhealthy granulation tissue. There is a surrounding interaction with red-colored skin, and 2 mobile lymph nodes palpable over the left axilla, largest measuring 2 into 1 centimeter, which is hard in consistency, belongs to anterior group of lymph nodes. An examination of other system, examination of respiratory system, normal vesicular breath sound, no added sound. Examination of the abdomen, soft, liver and spleen not palpable. Examination of thoracic spine within normal limit. Summary: 49-year-old perimenopausal woman who had first childbirth after 30 years presented with complaining of lump in left breast since last 3 years, with a history of rapid increase in the size since last 2 months, associated with nipple retraction since last 4 months, and an ulcer since 2 weeks without any symptoms suggestive of metastasis. No history of menstrual irregularity or abortion. On examination, left breast pulled upwards with the nipple retraction, with surrounding skin shows pudiorange and 2 into 1 centimeter ulcer at 6 o'clock position. A hard lump of 8 into 7 centimeter present at 6 to 2 o'clock position, involving nipple areolar complex, which moves with breast tissue with no fixity to the underlying structures. Its lateral hard, mobile, 2 lymph nodes, the largest one is 2 into 1 centimeter present in the left axilla. My provisional diagnosis: carcinoma left breast, clinical staging T4A, Edmund M0, and stage 3.
I can go backwards from here. How would it be T4A? Your skin is involved. Patient got ulceration, pudiorange. So that would be T4B, isn't it? And it's not fixed to the chest wall. T4A is fixed to chest wall, right?
Yes, sir.
Irene, sorry. Irene?
Yes, sir.
So how is it T4A? I think that's by mistake you've written. That should be T4B. Unless it is fixed to the chest wall also, then it becomes T4B. Can we start from the first slide, please, in the general examination? Remember, the first point you mentioned was performance status is 100 Karnofsky. Do you know nobody is 100? It's very difficult to be 100. And what is 90 if I was to go by your description?
She's able to do the normal activity with the disease.
So patient has symptoms. She's got disease. How would she be 100? She won't even be 90. She would be down to 80 because very minor symptoms are 100. So don't use that. No, in the examination, Irene. Yeah, here. So Karnofsky is not, I mean, if you want to be very, very, liberal, it is 90. But even that is not true with the kind of symptoms and the signs the patient has got. That is one very important observation. So don't mention it casually. It's important. And in fact, a lot of people use ECOG for this reason. It's more specific. What does ECOG stand for? Eastern Cooperative Oncology Group. They have a scaling where here 100 is good, there 0 is good. So it's the other way around, right? So please do not use it. 100 is almost never the case. The patient has always got some symptoms for which she has come. Next slide, please, quickly. Now, I'm not going to spend a lot of time here. Once you say there is peau d'orange, skin shyness, pinching, etc., involvement of skin can be straight away spoken. So that the examiner can ask you in a postgraduate exam, what are the features that suggest that skin is involved? What are the features that suggest skin is involved?
Purely orange, ulceration, and salivation.
Patient has 3 of them. So you should be able to say that the skin is involved. Rest happens. Rest are features based on which you came to that conclusion. Correct?
Yes.
Next slide, please. Now, this is when you mentioned I examined the patient in sitting, supine, and reclining position. You will be asked a question: why sitting, why reclining, why supine? So, why sitting?
Sitting, we can assess the nipple level, sir. And
So you would mostly inspect in sitting position, palpate in supine position. Because in inspection, you can compare it with a normal breast. Therefore, in anything paired in the body, always describe the normal side first, especially in the breast, because each woman has a different texture of a breast. Each breast is different. You will find it's a pathology, but it may not be. You would mention I examined in sitting position all these features. Level of nipple area complex, visible, and lifting of the arms to look for all the features that you actually mentioned, but I'm trying to put them in place. And there's nothing like healthy or unhealthy granulation tissue. What you're seeing is angiogenesis. Granulation tissue is in a healing wound. All right. So the rest of the description, I think many other people would ask you, so I won't barge in there. Go to the next slide. Now you described it. You mentioned the margin is raised. Can you go back to that picture? Sorry. Yes. So there are many features around it. It's not just one. And I'm sure when you see it in a live scenario, this is very close to chest wall. So that point would be asked. Which muscle you're looking for in the depth that you mentioned is not attached, not fixed? It's overlying which muscle according to you?
This one, serratus anterior, because this ulcer is present over the lower part of the breast.
So it is likely to be chest wall more commonly. I agree with you, but then that is what you need to describe. In supine position, you inspect better because the visibility, but you can see the upper other side, breast as well as axilla. And in in the sitting position. In supine position, you can palpate the lump against the chest wall because the breast falls apart. Both breasts fall apart, so you're able to appreciate better. And also you can see the inframammary fold better. These are the points that would indicate what you're trying to examine in 3 position. And reclining is the advantage of both. So if you want to take a middle path, that's a reclining position. Next slide, please. So the area is edematous. There is discoloration. Basically, skin is involved. So you can get away from that problem by looking at it. I think your slides have disappeared, but I think the point where you were, the involvement of the skin was quite clearly visible. So to mention the pinch and inch test or to look for, can you get your slides back or we move on?
1 second, sir. I think she's, Dr. Irene?
I think she's got logged out.
She got lost, sir. 1 second.
She got logged out, I think.
No, sir. We don't lock out anyone.
No, she probably logged out on her own. I mean, the internet must be an issue.
Let me check, sir. Dr. Irene, you are back with us?
Sir, 1 second, sir.
Yeah. You have some issues with your internet or something?
Yeah. Something happened. So, okay.
Are you fine now?
1 second, sir. The screen is pairing, sir.
You are fine, but you are not watching the camera what you are supposed to watch. Turn left.
No,
yes, that's perfect.
Yeah. Okay, fine.
You can adjust
actually,
your
but my system is
No problem at all. It's perfectly understood. Dr. Chintamani did mention that about it. And I think, sir, she's back, sir. Faculty, please take over. Narayanan sir, Kaliratnam sir, and Uday sir, please. Chintamani sir.
I'll just finish with 2 or 3
Please,
points.
sir, please go ahead, sir.
So, I remember the slides you had put beyond this. What I wanted to mention for the benefit of the postgraduates, examination of the breast is, if you quickly want to mention, the position in which the patient is always important, and describe in one go all the features. You don't have to say it in inspection, then on palpation, and then otherwise. If there is ulceration, it will remain the same. Maybe you can describe more features about it later, right? Especially in a postgraduate exam. And describe axilla separately, supraclavicular fossa, which you probably did not mention. You need to mention, and importantly, contralateral breast and contralateral axilla. I have more points, but I'll leave it there because I'm sure others would be asking. And lastly, did you examine the contralateral breast and axilla by any chance, if I may ask you?
Sir?
Did you examine the contralateral breast and axilla?
Yes, sir.
So was it normal?
Yeah, it was normal, sir. No
I-
palpable lesions in present over the right breast or axilla.
Suppose the right breast had no palpable lesion, but there was a lymph node in the right axilla. What would be your clinical stage? I have already corrected it to CT4B rather than A. What would be your clinical stage if there is a contralateral axillary node?
First, we have to do imaging studies to rule out any other lesions present on the right breast.
Clinically, I'm asking, which includes, of course, ultrasound with AJCC 8th edition today. But generally, what would you be clinically calling it? So in the absence of a primary in that breast, it will be a metastatic disease.
Metastatic
In the
disease.
presence of a primary, you will stage it separate, right?
Okay.
So I'll leave it at that. Maybe others can ask, and I'll get back. Thank you.
Thank you.
Other faculty, would you like to give your questions?
Irene, can you hear me?
Sir, I think they are just settling, sir. Irene, are you okay? Please unmute yourself. And request Dr. Jose to switch off the other computer because there is some audio issue.
Okay.
Yes, Doctor. Sir, Syrian sir, she is available.
Irene, the ulcer that you're describing, it looks more like a benign ulcer. But what you should say is granulation tissue, as sir was saying, it's more for a healing ulcer. Now, this will more likely to have necrotic. Now, the margin is raised, you have said again. It's often the edge which is raised rather than the margin. Margins, you usually say it's whether it's puckered or well-defined, whether you're able to make out whether it's regular margins and so on. It's the edge which is raised. Now, which other breast condition can give rise to ulcers with a lump? And how do you differentiate that clinically from an infiltrating malignancy?
We have to take a biopsy from the ulcer.
No. Clinically, what other breast lumps can give rise to ulcerations?
Satellite nodules.
No. Apart from malignancy, anything else?
Paget's disease. Phyllodes.
Phyllodes tumor. So
Yes,
how
sir.
do you differentiate that clinically from an infiltrating malignancy?
Phyllodes usually a soft tissue tumor, so usually it will be a hematogenous spread. Here, the axillary lymph node is palpable.
No. The ulcer, usually it's because of, what is it due to? Why do you get ulceration in a phyllodes tumor? It's because of the rapid growth.
Stretching of the skin.
It's something like a decubitus ulcer or pressure necrosis.
Pressure necrosis.
So you can usually pass a probe under the skin, which means it's an undermine. And
Okay.
unfortunately, there's another thing which can cause ulceration in India is tuberculosis. We're seeing more and more tuberculosis of the breast with ulceration and undermined edges. So when you describe, don't talk about granulation tissue, which is more specific for healing, and sloping edges. Sloping again indicates a healing ulcer. This is more of raised edges, bleeding. You are having a frank bleeding from the ulcer, spontaneous. So you talked about the discharge. Another thing in the abdomen, when you don't talk about spleen and things like that. More important is you look for hepatomegaly, ascites. That's what you not mentioned. And with premenopausal, talk about any ovarian lumps you're seeing, like Ruckenberg's tumor, Sister Joseph's nodule, things like that. You need to more specific. and always complete your examination with a per rectal and PV
That's
examination as a routine. Yeah. Otherwise, it's a nice presentation. Yeah.
Other fact,
Yeah,
Kanna sir?
what
Yes,
is a
sir.
what is a Crookenberg tumor?
Metastatic tumor to the ovarian system.
What are the characteristics of this Crookenberg tumor? Which patients are more likely to have the Crookenberg tumor?
Premenopausal women.
Okay. But can it occur in the postmenopausal also?
Not sure.
It can occur in postmenopausal also, no? Because initially it was thought there the transcelomic spread is there, but now it is the retrograde lymphatic spread is there. Okay. What are the other characteristics of that? So usually in the premenopausal, is it unilateral or bilateral?
Bilateral. It can be bilateral.
Yeah, usually bilateral, yes.
Bilateral.
Okay. Is it solid tumor or a cystic tumor?
You find difficult to answer, please tell
Yes,
so,
sir. I don't know, sir.
so that we can move on.
It is the bilateral, it's a solid tumor. You know?
Okay.
So characteristic of the Crookenberg tumor is usually in the premenopausal, bilateral tumor and a solid tumor, not a cystic tumor then. Okay. What is Bloomer shell?
Metastatic deposits in the umbilicus.
In the umbilicus?
Sir, which one, sir?
Bloomer shell.
It's in the pouch of Douglas, metastatic deposits in the pouch of
Pouch of Douglas, right. Now, what are the findings in the chest examination of a cancer breast patient?
Mostly patient will be presented with a malignant pleural effusion.
Okay. What else can be there? There can be consolidation also.
A consolidation also.
So how will you differentiate between a consolidation and the pleural effusion clinically?
On percussion, one thing is breath sounds will be decreased on the affected side with the dullness present over the affected side.
Both cases the same will be there. It will be dull, breath sounds will be decreased. Then how will you differentiate?
Tracheal shift.
If it is very massive is there, there can be shift may be there, shift to the mediastinum may be there. But anything which is increasing in the consolidation and decrease in the pleural effusion, okay, you do the vocal fragmitus. Vocal fragmitus and the resonance is done. That is increased in consolidation while it is decreased in the pleural effusion. What are the CNS features or the brain metastasis is there what you will look for? And how the patient will present with the brain metastasis?
New onset of epilepsy, seizure disorders, headache, and symptoms suggestive of raised intracranial tension, projectile vomiting.
So what are those symptoms and what is the triad of a raised intracranial tension? What is the triad of raised intracranial tension? Headache, vomiting,
And hyper.
and papilledema. So you have to do the fundoscopy to see for the papilledema. So this is the triad for the. All right. How do you test for the bone? There is a bony metastasis like the spinal metastasis is there.
Examination of the paravertebral area. Palpation, patient will have the pain.
So why you examine the paravertebral, not on the spine of the vertebra? Why do you examine the paravertebral area?
The transverse process of the vertebrae is usually affected.
Is the transverse process which is affected or something else which is affected? Which is the pedicle of the vertebra? And how does it look on the plain X-ray?
I don't know.
You can see the round bodies there, no?
Okay.
Owl size. Okay. And that is the pedicle. That is the site for the metastasis. And that is why you press it from the side there to elicit the tenderness in that area there. Are the metastases from the cancer breast osteosclerotic or osteolytic?
Osteolytic, sir.
Every time?
No, it is.
Can be both, no?
Okay, sir.
The osteolytic, but it can be osteosclerotic also.
Okay.
Which is the commonest osteosclerotic metastasis from the which area? What is the commonest primary? Prostate is the primary area. Okay. Okay.
Professor Kaliratnam, sir, can we move to the investigation or do you have any
Okay.
questions here, sir?
No question. You can go to the investigation part.
Go ahead, Dr. Iron, you move to the slides. Any other faculty comments? Chintamani, sir, can she move to the investigation part of it?
One
Syrian,
thing,
sir, yes, sir.
pectoralis major also will be an important part of the examination. I don't think she's mentioned. Involvement of pectoralis major, test whether it's adherent to it. Though it doesn't come in the staging, it's better because if you're planning a palliative mastectomy, you should know what plane you're going into.
Yes, sir.
And
And
if
it's
it's
not fixed the underlying structures of chest walls.
yeah, and if it's serratus anterior, what does it constitute?
It's a component of chest walls.
Chest wall, yeah. Okay.
Can
Go
she go
on,
ahead, faculty? Yes, sir.
Can move. I think we can move now. Yeah.
Yes, sir.
So investigations, first for for diagnosis, I would like to go with an imaging here with a mammography. And then investigation for the
No. First of all, you've done imaging. Will that be the end of it, or you would do more because you can't confirm it on imaging? No, that is
for
you have triple assessment here also. So you've done history examination, supposedly complete, and you know what are the? I mean, I want to ask you, although it may take half a minute, but it's important for all postgraduates. What are the AJCC 8th edition changes in staging of breast, and what approach to breast? Quickly, if you don't know, I'll tell you.
Sir, I don't know. Micro.
See, I'll tell you quickly. One is the lobular carcinoma and C2 part, which has been covered by you. Second is clinical staging is not done on clinical examination alone. You have to add ultrasound for the axilla. Axilla's axillary staging is done based on axillary, which is an extension of clinical examination only. So that is important. And there are a few other things, but this I thought I'll bring up for the benefit of staging. So you cannot say clinical stage CT4B N1 M0 subject to my ultrasound confirmation. It has become a part of standard clinical stage. Correct? So now, what do you do? Imaging, you said mammography. That's what you said?
Yes, sir.
What mammography? What views?
For the diagnosis, there are 4 views: craniocaudal, lateral, 90-degree lateral view, and a spot compression.
That's an excellent
answer.
That's an excellent answer. Now, what do you wish to see in a mammography?
The features suggestive of malignancy like microcalcification, structural artifact, speculation.
So you would come down to the BI-RAD staging, and we wouldn't waste time there. Everybody reads about it. So when it comes to staging, ThyRAD is for thyroid, BI-RAD is for breast, PI-RAD is for prostate, LI-RAD is for liver. Easy to remember. So you mention that, and then you can elaborate on it. I will not go deeper. Sometimes it's a painful breast. So mammography may not be feasible because patient may have pain. You don't want to cause that pain. So are there other methods to do the imaging to get the same answer that you're looking for?
Ultrasound.
Yes, ultrasound is one, but what is the disadvantage of ultrasound in this kind of a breast? It is very good.
Glandularity, dense.
Ultrasound is ideal for a dense breast. And also, if you have scarring, ultrasound is better than mammography because you may have a poor outcome. And why is mammography preferred in fatty breasts over the denser breasts?
An MRI.
No, did you hear me? Or you couldn't hear me, Irene?
Yes.
Why is mammography inferior to ultrasound in a dense breast?
Because it's asserting the glandularity of the.
I'll answer that. Parenchyma looks white and the lesion also looks white. So on mammography, they may not be able, it may not be easy to pick up. But a fatty breast, fat looks black. So the lesion would look white, it will stand against it. That's one. This is where MRI comes in, which is a problem solving tool. And in mammography also, they have added contrast mammography now, and also tomography that you can add on and on. But for you, mammography is the investigation of choice in this age group, which subject to, with the pain being a factor which I was mentioning, right? So please be clear on that. That's why I was asking you. What about the third part of the triple test that you would like to do here?
Histopathological diagnosis, tissue diagnosis with a core needle biopsy.
Core needle biopsy, you got an ulcer. Why won't you take an edge biopsy?
We don't know the skin is involved or not while we are taking the edge biopsy from the ulcer.
That's why that brilliant question that was asked by Professor, whether the skin involvement is due to the tumor or it is a part of the, the result of it, or it looks like a benign ulcer. So you have subjectivity there. Although it is allowed, but it's better and it's recommended to do image-guided core biopsy in most cases where there is a lump. You are more likely to get a diagnosis. And what do you do for the ultrasound? For the axilla, ultrasound, right? And what are the ultrasound features of a metastatic lymph node?
Sir?
What are the ultrasound features of a metastatic node?
There will be which will be oval in shape, round in shape with a loss of fatty hilum.
Or? So I'll answer that. Usually lymph node is oblong, and here it will become
round in shape.
One because of central necrosis, and second because of excessive infiltration. Secondly, fatty hilum is replaced, right? Thirdly, there is a loss of a halo, which is the capsule around the lymph node. We call it the halo sign. And central hypoechoic area, which is necrosis. These are four major features that we look for. Once you've done the imaging, core biopsy, what do you wish to see in the core biopsy or in the tissue?
To assess the type of the malignancy, grading of the tumor, hormone receptor status, in situ cancer from the invasive cancer.
Good. So I'll put it for your benefit in the order that you should mention it. One is, it will tell you about invasiveness. So you need to look for the first thing, whether it is a cancer which is invasive or not, which you cannot get on FNAC. Number two, grade of the tumor, type of tumor, and of course, biomarkers. You mentioned it all. I've just put it 1, 2, 3, 4. Because in that order, they are important. Correct?
Yes.
Now, what is the major disadvantage with FNAC?
We can't assess the in situ invasive, the same thing, sir.
Correct. And operator dependent.
Operator dependent.
Cytologist. Very much like ultrasound. It's operator dependent. You can have a good ultrasound with a good sonologist, but with mammography, the 4 views, that makes it absolutely clear. Would you do a metastatic workup here? That's my last question.
It's a locally advanced cancer, so we have to assess the CT chest and see contrast enhance the abdomen pelvis.
So Irene, your answer is yes. And then you answer the second question, which I did not even ask you, because you would have got 2 questions and you would have got more marks. So my question was, would you do a metastatic workup? The answer was yes. Then I'll ask you, what would you do for metastatic workup? Your answer would be CT thorax, abdomen, and pelvis, bone scan, right? And some smarter people would add PET scan to it, which is not really recommended as a routine. What kind of a recommendation is for PET scan?
For the local recurrence and
so the recommendation is category 2B, and you should know as a postgraduate, it's not absolutely indicated, but a lot of people swear by it. What's the problem of PET scan in this part of the world?
cost.
False positive. Very good. Due to what? Chronic inflammatory disorders. One which is rampant. Tuberculosis. You can find in the pediatrium, and you'll keep chasing till the cows come home, and patient would be dead. You would upstage for no good reason. So it becomes a problem. So a lot of us don't do it as a routine metastatic workup. Correct? So
Yes.
once you've done that workup, you mentioned that I'll do investigations for staging. That is also covered. Now, what investigation would you like to do for surgery? Suppose your stage is CT4B, N1M0. Would you go for surgery straight away, or you are going to do something else?
I will go for a neoadjuvant therapy.
Now, I'll make your answer even better, that I would discuss the case in a multidisciplinary team.
Yes. Okay.
Smarter way to answer. Surgeons don't take all the decisions. They are not molecular biologists, and they should not try to become. It's a good thing to have more people joining you in the team to give you an idea. If you were to take that decision in MD to put the patient neoadjuvant, what would be the reason?
So we can assess the in vivo sensitivity of the chemotherapy for adjuvant chemo, and we can offer breast conservative surgery to decrease the size of the tumor.
Irene, you're finished. Can I answer now?
Yes, sir.
So your answer is a little all. I mean, it is all over the place. So I'll put it in perspective. One, your patient is not a case for breast conservation, so we're not even discussing. Okay, but yes, in general, it can reduce the size of the tumor, downstage it, downsize it importantly, to facilitate clear margin and breast conservation in patients where it is possible. That's number one. Number two, it can take care of the micro metastasis in the system. That is a systemic disease. Number three, it can give you or provide you with the in vivo. It puts everything in one particular, I mean, I won't take all the questions here because I'm sure there would be other questions. You will put the patient on neoadjuvant chemotherapy and you will assess the response using what? How would you assess the response?
It can be a complete response, partial response.
My question was how? How? You're saying what? The question is how would you assess the response?
We have to place the clip over the tumors. Then,
madam, we again losing the plot. You put a clip when you're going to do conservation. Otherwise, it has no role, right? You put a clip to know where the tumor was if it disappears.
Yes.
So your answer to the question is, I will assess it using racist criteria. We teach
racist criteria.
And you know the answer. What is racist? It is spelled with R-E-C-I-S-T, not R-A. Oh, please be careful. Response evaluation criteria in solid tumors.
Okay.
And use imaging from the beginning till the end to assess that response. Clear?
Yes.
And with more than 50% responses taken as responders by some, more than 75% is very good response. And complete disappearance is CCR, complete clinical response. Which on pathology, if it comes out to be pathologically complete response, then it's PCR. I've taken you to a distance, so you'll put the patient on neoadjuvant. How many cycles, what drugs, etc., can be discussed by somebody. But importantly, that you should be able to mention why neoadjuvant, what neoadjuvant you should know, for how long you should do it. There are 6 to 8 cycles. Some people give 4 to 6. What regime is used commonly in your hospital? You can mention.
Anthracycline, cyclophosphamide with the paclitaxel or a methotrexate.
No, it can't be or methotrexate. Methotrexate is oblique adriamycin.
ACF regimen or AC with the taxane regimen.
So taxane based or without taxane, most people use taxane based. Would your core biopsy biomarker status affect your chemotherapy?
Yes, sir. We can offer hormonal therapy for the patients if the patient is ERPR positive, or if the patient is HER2 positive, we can offer Herceptin.
Good. And triple negative, you'll offer taxane-based chemotherapy.
Taxane-based chemotherapy.
What disease you must exclude before you put the patient on adriamycin or taxane? Underlying cardiac disorders.
Cardiac disorders.
I won't ask you in details. I think I can pass it over to Dr. Kanagavel now. I think we went a little far for that.
Other faculty, Kanna sir, Assyrian sir, Kaliratnam sir, Uday sir.
Okay. Neoadjuvant chemotherapy. I'm Dr. Kaliratnam.
Yes, sir.
about what is the difference between the neoadjuvant and adjuvant chemotherapy?
Neoadjuvant is given before surgery and adjuvant is given after surgery, sir.
What's the concept behind that? Do you expect any advantage over this preoperative chemotherapy?
Yes, sir. We can assess the response preoperatively. If the patient is responding well, we can continue the same regimen postoperatively, or we have to change the regimen.
Okay. Is there any advantages in terms of disease-free survival and lengthening of the survival or relapses, recurrence between the neoadjuvant and the adjuvant? Is there any difference in the outcome? There is no difference in the outcome.
No difference, sir.
Before preoperative chemotherapy is given preoperatively or postoperatively, it doesn't make lengthening survival, disease-free survival rate are all equal. But only the main advantage is can inoperable become operable. The operable disease become conservative breast surgery. That's the main advantage of this pre-surgical chemotherapy or neoadjuvant chemotherapy. Okay, you have to assess. You can assess 3 cycles. After 3 cycles, if it response is good, you can continue up to 6 cycles. If it partially responds, then you can change the regimen. And as you said, like that. Okay. Suppose.
Aaron,
Any other?
what are the various surgical treatment for the cancer breast?
Cancer, it's a breast conservative surgery and modified radical mastectomy.
Apart from these two, there are no other surgical treatments for the breast cancer? If there's a modified radical mastectomy, there has to be a radical mastectomy also, isn't it?
A simple mastectomy, radical mastectomy, and modified radical mastectomy.
Okay. What is the supra-radical mastectomy?
I don't know, sir.
The supra-radical, where you are removing also the chest wall also.
Okay, sir.
So can you tell what is the classical Hosted radical mastectomy? Though it is not done, but you should know that. Everything started with the Hosted. So what is the Hosted radical mastectomy? Yeah.
Removal of the breast tissue along with the axillary tail of spens involving pectoris minor and major with clearance of level 1 to 3 lymph nodes.
So do you remove the whole of the pectoris major?
No, sir.
What are the parts of the pectoris major? Because there are 2 parts are there. One is the sternal part, another is the clavicular part. Okay, so you are removing only the sternal part of the pectoris major, but not the clavicular part of that. And the reason for that is there is a very important vein which is running in that area there, in this group which is there. Cephalic vein is there.
Yes, sir.
You do not want to disturb that vein, because otherwise if you disturb that vein, there is a very high chance of having the post-operative lymphedema there.
Okay.
Okay. So you are removing a part of the pectoris. Okay, so that is the. Now tell what are the various types of the modified radical mastectomies?
Patties, ocean blows, Stanlons.
Okay, what is patties?
Here, pectoris minor is removed, Stanley's pectoris minor is cut, and ocean close it is retracted.
So when you're doing the patties mastectomy, from where you detach the pectoris minor? What are the structures it is attached? Pectoris minor.
Postoclavicular, we come into the coracoacromial process.
The coracoid process, is attached to the coracoid process, and below where it is attached? Third, fourth, and fifth.
Third, fourth,
Third,
fifth,
fourth, and
vertebral.
fifth ribs, yeah. Okay, is it
Right,
right?
ribs.
Right. So when you're doing the Scanlon variety, from which side you detach?
Coracoid part, sir.
Coracoid.
Coracoid.
Right. You remove from the, you detach it from the coracoid side. Right. Now, what are the various nerves you are going to save during the modified radical mastectomies?
Thoracodorsal nerve, nerve to serratus anterior, medial and lateral pectoral nerve.
So do you visualize both the nerves, medial and the lateral pectoral nerve?
Yeah.
Which one is usually visualized?
Lateral pectoral nerve.
The medial pectoral nerve. Okay, it's the medial pectoral nerve which is usually visualized at the pectoris minor area. What other nerves will be coming?
Thoracodorsal and nerve to serratus anterior.
Yes. What other nerves?
Intercostobrachial nerve.
How many intercostal brachial nerves are there? They're usually multiple, no? It's not that it is just one intercostal brachial nerve is there. So if you detach the intercostal brachial nerve, what is the problem? If you cut that, what is the problem?
Patient will have neuralgia over the chest wall. Neuralgia.
Where?
Lateral part of the chest wall.
Is it a neuralgia or anesthetic patch is there?
Anesthetic patch.
Where?
Inner part of the arm.
Yeah, inner part of the upper arm. No?
Upper arm.
Right. Now, what are the various ways to prevent the seroma formation? That's a very common complication which is there after MRM. So, what are the various ways to prevent the seroma?
Postoperative drain placement and compression bandage.
So, what type of the drain you are going to put?
Closed suction drain.
Suction drain. Okay. Any other things? Okay, you have to take care of all the small lymphatics also.
Okay.
Okay. Not much use of the diathermy in that area. Some people, they use a glue to that those flaps which are there, they are attached to the underlying structures there. Okay, and there are various views to what type of the suction drain should be put, whether it should be full compressed suction drain or it should be half or it should be not there. Usually it is that in midway between that. You know, when you're putting the suction drain, it should be midway between that. You know? Right. Okay.
What is the role of radiotherapy since it is a locally advanced cancer? What is the role of radiotherapy in this case?
To address the local recurrence.
No. What are the indications? When do you use radiotherapy?
Generally,
Preoperative or postoperatively?
postoperatively, sir. If the tumor size is more than.
In this case, can you give preoperatively? You can give preoperatively also. Locally, civil advanced cancer, you can give as a neoadjuvant. Okay. What are the indications of radiotherapy after post-mastectomy? Post-mastectomy.
Mastectomy, okay. If the lymph node, more than 4 lymph nodes, and if the axillary sampling is inadequate.
First, tumor size. Any tumor more than 5 centimeters. Yes. Then grade, yes, grade. Then margin. Margin.
Post-it.
1 millimeter or close to margin. These are all indications pertaining to the tumor site, you know. And coming to the axilla, bulk, depending on the bulk of the metastasis or lymph node more than 3. These are the indications. Or any area you are not operated, missed areas of surgery.
Okay.
These are the indications for radiotherapy after surgery in locally advanced case. Okay. Any indications for radiotherapy in a early breast carcinoma?
Early breast
What type?
carcinoma, if we are going for a breast conservative surgery, we have to give radiotherapy.
What type of radiotherapy will go in that case?
Accelerated beam.
No, usually it is linear accelerator, depending on, okay, it is targeted towards by linear accelerator radiotherapy. That will be targeted towards the more on the radiation towards the tumor site. So, okay. There is no role for nowadays. It's a extra EBRT, external beam radiation therapy. It is only for metastatic disease, or nowadays it is not used in early breast carcinoma as well as in advanced cancer also. Okay. What are the hormonal therapy? What are the drugs you will give for hormone therapy?
If it's
Endocrine therapy, otherwise
ERPR
endocrine therapy.
If it's ERPR positive in a premenopausal woman, we will give the tamoxifen. If it's a postmenopausal woman, we will give the aromatase inhibitors. If patient is Herceptin positive, we'll give transition.
See, tamoxifen, how long you will give?
10 years.
How long you can give? Now it is
10 years.
10 years.
Now it's 10 years.
So, yeah, it is 10 years. Good. Along with the Trastuzumab, any other drug you can add if there is get a more advantage. Along with the Trastuzumab.
Pembrolizumab.
Pertuzumab. Pertuzumab. Oh.
Okay.
Okay.
See, for Irene, for radiation, very correctly brought out.
All the surgical. Okay. Okay.
Sorry, you're speaking. Carry on. Hello.
Please go ahead, man.
Yeah, Irene, for radiation, the earlier rule was 3, 4, 5.
Yes, sir.
We'll teach them.
Grade 3.
4 out of
4
10 nodes and 5 centimeters. But this is obsolete now. All LABCs get radiation.
Okay.
Even one node, they're giving radiation now, 1 to 3. There is a 1 to 3 trial where now they're giving it to all. Extra capsular spread, angiogenesis, they are all factors. Clear? All LABCs, all means all. Please, I'm repeating it. All LABCs get radiation. There is no confusion. But radiation, if it is given to axilla, it is done if there is a suboptimal axillary dissection. And as you correctly mentioned, if there are less than 10 nodes dissected, it is suboptimal. So they would like to give radiation. Otherwise, you don't need to give it. You will produce lymphedema. And very correctly brought out, sequencing does not change the overall outcome. So whether you give before or after, it doesn't matter. But everything given before has an advantage of an oxygenated tissue, which responds better, whether it's chemo, radiation, or whatever. Okay. Now, coming to this is not called linear accelerator is a device. You give conformal radiation. It's called conformal. And EBRT is the other one, right? Which is better. Conformal can preserve the heart, lung, etc., and also the other part of the breast. And one of the conformal ones is APBI, but there are many: IGRT, IMRT, brachytherapy. Okay, so that will put it in right perspective. And for that reason, when you're doing your conservation, you leave the clips in the tumor bed for the boost. Okay, but your case is a case where you would not be even thinking about conservation. This would require
modified.
Yes, and of course, Hallstadian mastectomy is obsolete and nobody does it. But sometimes you may extend beyond your barriers to remove the part of peculius major, which if it is involved, you would remove it. Secondly, when you're doing whichever, nobody cuts peculius minor now, Patey's is also obsolete. We will always retract pec minor and get a level 3. That was the reason why they were cutting it earlier. And the important thing which was brought out was medial and lateral pectoral nerves, because there's no point preserving peculius major without its nerve supply. And medial is lateral and lateral is medial in its location, right? You can find both, but of course, medial is easier to find. It's at the lateral border of pectoralis minor. Yeah.
Yes.
Thirdly, the medial limit of axillary dissection is Halsted ligament. Superior limit is axillary vein, and inferior limit is angular vein. Lateral boundaries, Letzmann's dorsal. You should know this. This is about axilla. Coming to the conservation, it's not applicable here. All patients with breast conservation would require radiation, regardless of who the case is or what the case is. If you cannot give radiation, you don't do conservation. But all LABCs also require radiation. There's no exception to the rule. What are the contraindications to giving radiation? Previous radiotherapy, collagen vascular disorders, yes, and a low performance status. That is why performance status is important. If the patient's performance status is less than 60 Karnofsky, she is not fit even for a haircut. You can't do surgery, you can't do chemo, you can't do radiation. All of them are going to be harmful to the patient. So we need to be clear on that. That is why you discuss the case in the MDT. Regarding the hormone therapy, 5 years is what is considered usually done, but you can add 5 more years based on ATOM trial. They found that it is beneficial. Or you can do switch therapy. That is 3 years of aromatase inhibitors in a postmenopausal, followed by tamoxifen for the remaining time. That's a switch therapy. Why premenopausal you should give tamoxifen and not aromatase, and the other way around for postmenopausal? You mentioned that. Why?
Because in premenopausal woman, the estrogen mainly from the ovarian, and the postmenopausal, it is mainly peripheral conversion of the estrogen. So we have to give the aromatase.
So premenopausal would be mainly the source is ovary. And this is, functioning ovary that you talk about. If the patient has no, ovary, cystosalpingo-oophorectomy has been done, then it's a different clause. But still, obese individuals will continue to make estrogen from the peripheral conversion. So that is why you need to be careful in giving that answer. Perimenopausal, it's a gray zone. But if the patient gets menopause during any time, you give aromatase. What side effects would happen with tamoxifen and what would happen with aromatase? Quickly, if you could tell us.
Tamoxifen, patient will have endometrial hyperplasia and DVT, vascular embolism, DVT. And aromatase inhibitors,
and possibly cancer. Endometrial cancer also is possible. So they need to be for regular, gynecological examination. Postmenopausal?
Osteopenia will be there.
Osteopenia. What does tamoxifen do to the bone?
Tamoxifen usually bone friendly.
So it will lead to deposition. So I would not go why. You can read about it. That is mostly theoretical. Yeah. And we do not usually go for anything more than the standard modified radical mastectomy, where preservation of pec minor is a part of it. Petty is not done. Ocean clause, what used to be called, is what is done. And most people would be able to reach level 3 to get that. Thank you.
Usually, see, in axillary dissection, whatever may be the name, so the aim is to remove level 1 and 2. Whenever there is a level 2 is extracapsular, I think it is extracapsular mission, or tumor is very large tumor located in that level 2, then only you can go for level 3 dissection. Usually, in the case of MRM, you should not do level 3 dissection. Only level 1 and 2 should be removed.
The answer to that is level 3 is in most scenarios, because the burden is heavy, right? What you're saying is in the textbook of Bailey now.
Yeah, sir.
The reason I'll tell you for that is that also you should know. In the absence of level 1 being positive, the chances of level 3 being positive are less than 1%. Did you get it, Irene? So there is no reason for doing it. That is why they say you should not do level 3 if level 1 and 2 are not present, because then you'll add to the risk of lymphedema. That is what is correctly mentioned. But to say I will never do it is like never say never. In the presence of a node in the axilla, especially in Indian scenario, the classical modified radical mastectomy, as we teach, goes up to Halsted ligament. Correct? So level 1 and 2, if they are in a node negative axilla, that's why do not just get the idea from a book which is Western. Most of the time, people leave it when they do level 2 also. Can you tell me what are the boundaries of level 2? So that then you would know how much is level 2. Lateral limit of level 2.
Level 2.
Lateral limit is lateral thoracic pedicle, right? So medial limit you do not know, and you say pec minor medial border is the medial limit, but pec minor is on a sling. When you pull it, you can change it wherever. In fact, in the initial days, we used to put a clip in the level 3 for the radiation oncologist to irradiate if you have not removed it. So please understand, take it with clarity. Level 1, 2 being positive, level 1 positive, level 3 has to be cleared. Most of us will have to. If it is negative, yes, you can do up to level 2. And I gave you the evidence for that also. Level 1 being positive, 3 is likely to be involved, but when level 1 is negative, the chances are less than 1 to 2%. But even that is quite significant as far as our patients. You got it?
Okay, sir.
Dr. Kanageval, we are done.
Yes, sir. I think we have overshot the time also. The discussion was so intense, I didn't want to stop the discussion.
Sorry about that. It went on.
Kanna sir and CDN sir, would you like to add something? Uday sir?
I think it's already up now.
10:30.
10:30, yeah.
Thank you.
CDN sir?
Yeah, thank you, Dr. Kanagavir.
Thank you, sir. And Karnakaran sir, are you about to ask some questions? Sorry.
No, sir.
And we have the mentor for the student, Professor Adesh Gopal, who has been always quietly watching all through. Would you like to add something, sir? Sir, you are in mute mode.
Yeah. It was quite an engaging discussion. Our PGs are actually privileged to get connected with your stalwarts like Professor Chintamani sir and other Ajay sir, Narayan sir, Kaliratnam sir. So we are quite happy about that. So thank you all from on behalf of our MMC Calicut. Thank you, sir. Thank you, Kanageval sir.
Thank you, sir. Iron, it's been you've been asked questions by across the country's national faculty. Would you like to have any clarifications? We normally allow the students to ask questions if you require any clarification.
No, sir.
Thank you very much, Dr. Iron. And Chintamani sir, special thanks to staying with us for all the 2.5 hours. CDN sir, Kaliratnam sir.
Thanks for that.
Uday sir, are you with us? I think he has left. Ajay sir, thank you very much. Kanna sir, Karnakaran sir, thank you very much. We look forward for next Friday. Chintamani sir, we wish you could join more often. Because I remember you were in the earliest sessions and then in between couple of times. With God's grace, we have been doing this continuously. We have 185 sessions completed so far, sir.
Congratulations. Many congratulations. Phenomenal.
Thank you very much, sir.
Whenever you want me, I'll be there. Thank you.
Wish if you could join us on Fridays at your convenience. We are most welcome, sir. We'll be happy to have your grace upon us. Thank you very much. Syrian sir, thank you, sir.
Thank you.
Kaliratnam sir, thank you, sir. All other faculty, thank you. Dr. Aparna and Dr. Iron, best wishes from all of us. Good luck to you. And with the permission of the faculty, I